Good morning, everyone. On behalf of the Ceylon College of Physicians and the Sri Lanka College of Pulmonologists, it is my great pleasure to welcome you all to the Ceylon College of Physicians Specialty Update on Respiratory Medicine titled Concise Respiratory Updates for the Busy Physician. Today's program brings together leading experts in respiratory medicine to provide practical and guideline-based updates on the important respiratory conditions encountered in everyday clinical practice. Before we begin, I now invite the immediate past president of the Ceylon College of Physicians, Vidya Jyoti, Professor Prasad Khatlanda, to welcome you all.
Good morning, everyone. On behalf of the President CCP, Professor Namal Vijay Singh, who is unable to be here today due to an important official commitment, let me all welcome you to this specialty update on pulmonology. The CCP conducts several specialty updates on specialties with the collaboration of other colleges, the sister colleges, to update the membership. So this is a mandate that we take very seriously at CCP, and we conduct several specialty updates in the year. And this year we have already done 3, and this is the 4th such that we are going to do today. And for this, actually, we have selected pulmonology, where we are going to cover very important topics which are important both for pulmonologists as well as all other medical specialists, which are common things which everybody should do, and also which is very important for the trainees. So we are going to discuss on understanding community-acquired pneumonia in clinical practice. This is going to be delivered by Dr. Sachini Senaviratna, followed by clinical approach to pleural infections by Dr. Chandana Dahanayaka, and systematic and guideline-based approach to connective tissue disorder associated interstitial lung disease by Dr. Atihai Srirangan. And then non-cystic fibrosis bronchiectasis, evolving concepts and clinical strategies by Dr. Niranjan Chandramal. And the last one, right heart in lung diseases, a practical approach to co-pulmonale by Dr. R. Manmadan. And this is going to be followed by expert panelist discussion. And so I can see that we are going to have a very, very fruitful, very informative expert deliberations today on pulmonology. And I will invite all of you again, and also would like to have all of you throughout the meeting. Thank you very much.
Thank you, sir. I now invite the president of the Sri Lanka College of Pulmonologists, Dr. Sumana Handagala, to speak a few words.
Good morning, everyone. And again, as Prasad said, I welcome both physical as well as online participants for this course. And the respiratory medicine is quite pertinent, because I congratulate the CCP to have such sessions. But respiratory medicine, the respiratory component accounts for about 30 to 40% of morbidity among all present nations. A recent study done in Cultural District and one in Kandy showed nearly 30 to 40% account for respiratory symptoms. So it's good to have good knowledge of respiratory medicine, initial management, and when to refer the patients to specialists and all. And I would like to, Dr. Prasad actually mention about the speakers. There's a good array of topics as well as eminent speakers to talk on everything. And I would like to congratulate Dr. Niranjan Disanayaka, our leader. He's one of our past presidents, and he's a very good organizer. He prepared this course well ahead of this one, had Zoom meeting a few days ago to organize everything without wasting time. So I congratulate, and please get the best out of the course. Thank you very much.
Thank you, sir. Our first lecture is Understanding Community-Acquired Pneumonia in Clinical Practice by Dr. Sachini Senaviratna. Dr. Sachini Senaviratna is a consultant pulmonologist currently attached to the District General Hospital, Navalapitiya. She completed her undergraduate education from the Faculty of Medicine, University of Peradeniya, and obtained her MD from the Postgraduate Institute of Medicine, University of Colombo. Ladies and gentlemen, please welcome Dr. Sachini Saraviratna.
Thank you. Good morning, everyone. I'd like to thank the President and Council of the Ceylon College of Physicians for this invitation. So I've been given 15 minutes to discuss about understanding community-acquired pneumonia in clinical practice. So I'll keep everything brief and hope I'll keep you all up. Right. So this is the brief outline of my lecture. So how to identify pneumonia, the microbiological diagnosis, severity assessment, choice of antibiotics and duration, and also the use of steroids. Okay. So definition. So pneumonia acquired outside the hospital or healthcare facility is referred to as community-acquired pneumonia. So pneumonia, pathological term, basically means fluid in the alveoli. So fluid in the alveoli could be due to many etiologies. So here we are referring to infective causes, and of that community-acquired pneumonia, we talk about bacterial and viral pneumonias. There are other infective agents such as fungi which can cause pneumonia, but that is mainly among patients who are immunocompromised, and the guideline that I'm discussing today does not address this group with acquired or inherited immunodeficiencies or chemotherapy-related neutropenia. So the guideline that I've taken for this discussion was put out by the American Thoracic Society in conjunction with the Infectious Disease Society of America in August 2019 on diagnosis and treatment of adults with community-acquired pneumonia. It was updated in 2025 by the American Thoracic Society. Bulk of the guideline remains the same. There are only a few things that have changed, and I will highlight those points. And some of those points were not endorsed by the IDSA, which is why it was put out by ATS alone. Okay, so how do you diagnose pneumonia? So what do you really need to have to call it pneumonia? So a newly recognized pulmonary infiltrate on chest imaging is a must, right? Which is why we have been repeatedly advocating to do chest X-rays in patients who present with respiratory symptoms. So in the newest ATS guideline, lung ultrasound is also taken as a valid tool to identify pneumonia. But the problem with using ultrasound is that we don't have means of recording the image for another person to see, and therefore it's very difficult when it comes to continuing the patient's care to use ultrasound. So chest X-ray is widely available. It's not difficult to perform unless the patient cannot be mobilized at all. There is really no reason why in Sri Lanka you can't perform a chest X-ray. So imaging is a must to diagnose pneumonia. In addition to the imaging, there will generally be at least one respiratory symptom in the form of cough, sputum production, dyspnea, or pleuritic chest pain, and at least one other finding such as abnormal lung sounds, fever, leukocytosis or unexplained bandemia, or hypoxia. Right. So coming to microbiology, so the common pathogens that we encounter are Streptococcus pneumoniae, Haemophilus, Mycoplasma, Staph aureus, Legionella, Chlamydia, and Moraxella. But there is this group of organisms that we are very concerned about, which are multi-resistant, namely MRSA, Pseudomonas, and also multi-drug-resistant Enterobacteriaceae. And viral pneumonia is another category that we need to discuss. Right. So do we always need a microbiological diagnosis to treat pneumonia? So that is a topic that has always been under debate. So what are the arguments for going for a microbiological diagnosis? So it will enable you to identify a resistant pathogen. Therapy can be narrowed from broad spectrum to a targeted. Some pathogens such as Legionella have public health implications, and therapy may be adjusted when patients fail the initial therapy. And you can identify the constantly changing epidemiology of community-acquired pneumonia around your community, which is actually very important, particularly with something like pneumonia. We can't adopt what is told in another country and say this is what we should all be doing, because the microbiological pattern is different from country to country. So in order to get that epidemiological data, we need to test more and more. But there are problems with testing, right? So these are the general tools that we can use to identify the organism. These are sputum culture, blood culture, urinary antigens such as pneumococcal and Legionella urinary antigens, which to my knowledge is not performed anywhere. I would like to confirm with the microbiologist consequently in the panel, and molecular testing. Right. So sputum culture, it's widely performed. We, as a respiratory physician, I ask people in the medical wards to perform this more and more, but the overall yield is poor, right? And the yield depends on the quality of the specimen, and also the prior antibiotic use also influences the yield. So the earlier you do it, the better. Overall, when you take the evidence, there is no evidence to show that routine testing improves patient outcome. Okay, so I will highlight this as we go. So if we talk about the patients who can be treated as an outpatient, or as or the patients who have non-severe pneumonia, the usual antibiotic protocol works for most of them, and testing to find out what pathogen is causing it has not improved the patient's outcome. However, that being said, there are specific indications for it to be definitely performed, right? So these are indicated in patients with severe pneumonia, in patients where MRSA or Pseudomonas is suspected, right? We have to perform sputum culture, and along with that, we have, as subject to depending on the facilities available, we have to go for blood culture, urinary antigens, and also molecular testing. So blood culture is freely available to most of us in most hospitals. So please go ahead and do that. There are many, many instances where previously unsuspected stamp was identified by blood culture, and that has changed the patient's outcome, right? And so molecular testing is available in very limited centers and in the private sector, and is very expensive. To my knowledge, as I mentioned before, urinary antigens are not performed. So we need to identify whether the patient has a severe pneumonia or not to guide our investigations and management. So what are the tools to assess the severity? So Curve 65 was what we've been taught. I was taught when I was a medical student. It's a very rigid system. They say it's 0 to 1, outpatient, 1 to 2, ward, blah, blah. So it uses a very limited set of criteria to diagnose whether the patient is having a severe pneumonia or not. There are many aspects which are left out or not considered. So pneumonia severity index is much better in that sense, and uses many of the other aspects of a patient with a bad pneumonia, but it's not very practical to use. It's got a complex point system. So ATS and the IDSA together has set down a set of criteria which are actually very practical and useful. So this is the ATS IDSA criteria. So if you have either one major criteria or 3 or more minor criteria, you can diagnose severe pneumonia. So the major criteria is a no-brainer, very easy. So if the patient is in respiratory failure, they've got a severe pneumonia, respiratory failure requiring mechanical ventilation, or septic shock needing vasopressors. So the others are a little more nuanced: respiratory rate more than 30, PaO2 to FiO2 ratio less than 250, multilobe infiltrates, confusion or disorientation, uremia, leukopenia, thrombocytopenia, hypothermia, and hypotension requiring aggressive fluid resuscitation. So if you have 3 out of those, you can diagnose severe pneumonia. Right. So how do you choose an antibiotic? So choice of antibiotics broadly depends on these 4 factors. Are we dealing with a severe or non-severe pneumonia? Is there a history of recent hospitalization and parenteral antibiotics within the last 90 days? So you would realize I didn't mention the previously talked about category called healthcare-associated pneumonia. Okay, so that entity is not spoken of anymore. So they are also considered community-acquired pneumonia, but our antibiotic choice will differ if they have had a recent hospitalization or parenteral antibiotics within the last 90 days. Is there a history of MRSA colonization or infection anywhere in the body within the last 1 year? Or does the patient have a positive nasal PCR for MRSA? is there a history of Pseudomonas aeruginosa colonization or infection at any site within the last 1 year? Or is there advanced structural lung disease? But it is a very, very important point. Right. Okay. So this might look like a crowded slide. Why I chose this, because it gives a very good summary of all our antibiotic choices. I will read it out to you. So if we are dealing with a non-severe community-acquired pneumonia, the standard regime is to give a beta-lactam plus an atypical cover, which we are all very familiar with. So you can give either coamoxiclav, ceftriaxone, or cefotaxime in combination with azithromycin, clarithromycin, or doxycycline. This is something we all know. But if you have to give a monotherapy or an alternative therapy, they recommend levofloxacin or moxifloxacin. Now, this is not something we advocate as Sri Lankan respiratory physicians. I will come to this point later. This is given in the IDSA guidelines. So, the standard regime does not change in non-severe pneumonia. There has been a recent hospitalization or parenteral antibiotics in the last 90 days. Okay? So, even if there is some healthcare association, if the pneumonia is non-severe, the antibiotic choice does not change. Okay? If there is a risk factor for MRSA, you add on an MRSA cover, which could be either vancomycin or linezolid. Or if there is a Pseudomonas risk, for the beta-lactam, you choose a beta-lactam that covers Pseudomonas, right? So the standard regime had coamoxiclav, ceftriaxone, or cefotaxime, which changes to piperacillin, tazobactam, cefepime, ceftazidime, imipenem, or meropenem. All right? And the atypical cover does not change. And then when we come to severe pneumonia, the standard regime, the only difference in patients who have no other risk factors or no previous hospitalization is that there is no place for monotherapy. So you have to give a beta-lactam plus an atypical cover. So levo and moxifloxacin is only listed as an atypical cover and not as a cover for the general organisms. Okay, so if there is a recent hospitalization, then you have to add on an MRSA coverage and cover Pseudomonas with your beta-lactam by giving something like pictazole, cefepime, or ceftazidime, imipenem, or meropenem. Right? So if it's a severe pneumonia with an MRSA risk factor, to the standard regime, you add vanco or linezolid. And if it is a patient with a Pseudomonas risk factor, to the standard regime, for the beta-lactam, you add a beta-lactam that covers Pseudomonas. Right. So then we come to viral pneumonia. So here when I give the term viral pneumonia, I'm talking about a patient who has come with a new pulmonary infiltrate on chest X-ray, who has a confirmed virus isolated on nasal PCR, either RSV or influenza. So a confirmed viral pneumonia. So do we give antibiotics to these patients? This has been a constant debate. So what you have to understand is that we are now moving away from the thought that pneumonia is something that always comes from outside. So we are moving away from the thought that the lungs are a sterile space. So the lungs are full of all sorts of microorganisms. So when our body dynamics change, immunity drops due to some other reason, these bacteria do come up and create infections, which is why we are talking about MRSA colonizers having MRSA pneumonia. Okay, so those with viral pneumonia, when they go into severe disease, their mortality goes, just been shown that the mortality is related to bacterial infections. Okay, so in the ATS update that they made in 2025, they have recommended routine use of antibiotics in all patients with confirmed viral pneumonia, except those who are managed as outpatients with no comorbidities. So whenever you blanket and recommend antibiotics, what you have to balance is the antibiotic stewardship. Okay, so we are dealing with a full-blown viral infection in the community. If you're dishing out antibiotics to everyone, you're risking resistance in the community, which is why those who have no comorbidities and are treated as outpatients, who are stable enough to treat as outpatients, are not recommended to give antibiotics. Okay. And what is the place for steroids? Okay, so it is definitely not recommended for non-severe pneumonia. So recently evidence has come up that it improves the prognosis in those with severe pneumonia. So it is recommended in the ATS guideline, but there is a specific statement not to give for influenza pneumonia. Because as you know, in influenza, there is a very high risk of secondary bacterial infection, particularly with causing very high morbidity. So influenza pneumonia is excluded from the recommendation of using steroids. So I'll just take a few more seconds. So what are the challenges of implementing Western guidelines to our practice? So outpatient treatment of pneumonia is difficult, as you have all experienced, difficult to effectively safety net our patients because we don't have a robust primary care setting. And then the other aspects are melioidosis and tuberculosis. So melioidosis can present as severe acute community-acquired pneumonia in endemic regions. So that is something we have to keep in mind. And about respiratory fluoroquinolones, you would have seen they recommend as monotherapy for stable pneumonias treated as outpatients. But these are very effective anti-TB agents, and we've been telling this over and over again to not liberally use these drugs for everything. We see them given for sinusitis, UTIs, everything, right? So when there are alternatives, please use the alternatives. And since we don't have very robust system of identifying organisms, should we be routinely screening all patients for MRSA? And should we start decolonizing our patients, or should we be isolating as a practice? And then most of these guidelines do not recommend follow-up imaging. So as you know, all pneumonia should have an X-ray 6 weeks down the line to see if the shadow has resolved. But that is not recommended in the modern guidelines because most of these countries have effective lung cancer screening programs. But we do not. So this is a golden opportunity to actually identify some of these patients. So please carry on with your practice of follow-up imaging. So that's all I have to say. Thank you very much.
Thank you very much, madam, for that insightful presentation. We have a small reminder from the organizing committee that there will be a bell rung when there is 3 minutes left of the presentation. And on that note, we now move on to our second lecture on a clinical approach to pleural infections by Dr. Chandana Dahanayaka. Dr. Chandana Dahanayaka is a consultant pulmonologist currently attached to the District General Hospital, Hambantota. He completed his MBBS degree with honors and later obtained both the diploma in chest disease and tuberculosis and the MD in medicine. Please join me in welcoming Dr. Chandana Dahanayaka.
All right. Good afternoon, ladies and gentlemen, and thank you, Ceylon College of Physicians, for giving me this opportunity. We'll move on, going back to pleural infection from pneumonia. We'll start with a case. So I got a 52-year-old gentleman who had fever and productive cough for past week and coming to the ED with pleuritic chest pain, and he's septic, and the X-ray looks like he got a quite organized collection, right? Isn't it? And then the ultrasound shows again pleural collections with some particulate matter, which indicative of pleural infection or empyema. Right, so as per the definitions, what is the pleural infection? So it's a bacterial entry and the replication in the pleural space. And BTS guidelines states that an association of pneumonia is always a requirement. Given the fact, we name it parapneumonic effusions, and out of that, about 40 to 50 of comprise of bacterial pneumonia, and most of the time it goes like improve with just only with antibiotics, and out of that, about 5 to 10% will lead to empyema and needing some surgical intervention. So complex medical procedures. Right, so we all know by heart the transudative and exudative causes, and the parapneumonic effusions are always exudative. And in terms of investigations, imaging, chest X-ray, so don't forget, always go for lateral X-ray. So we get a better idea, better anatomy. In the instance like that, we don't have ultrasound video available, and in the top imagings, the left hand is the mild effusion, and the middle one is the moderate efficient, and the last image is how do you see the passive effusions. And in the top right, the CT appearance, so we call it the pleural split signs, so which is, I would say, a pathognomonic for empyema. And yeah, so that's the imaging that we can do. And based on the ultrasound findings, we can just categorize into a simple, parapneumonic versus complicated. This is based on the ultrasound guide, right? So if the effusion is more than 1 centimeter, it's usually amenable for aspiration, and we call it simple if it's showing flowing fluid. And if we see septations, pleural thickening, so like in particulate matter, then we call it complicated. Right, so this is how we measure the interpleural distance. So the distance in between the parietal and the visceral pleura at the lung base. So if it's less than 10 millimeters, so we call it pleural effusion with no significance because we can't aspirate that, right? Just give some antibiotics. And then this is how we measure the volume. There are certain ways to measure the volume. So if it's less than 500, we call it small, and moderate 5 to 1,000. And if it's more than 1,000, we call it large. Right, so these are the septations. And if you see this, so it reflects a complex parapneumonic effusion. And again, you can see a very particulate matter in the left-hand side and also the pleural nodule. So this also reflects a complex parapneumonic effusions based on the ultrasound guide. Right, so coming back to the pleural fluid analysis, which is the main part. So we need to do the cell count and the differential because we know we expect to have polymorphs in the parapneumonic effusions, and in TB effusion we expect to have lymphocytes. Gram stains, this is like one of the underutilized investigations, and if we see the send the fluid, and if they see either gram negative or gram positive bacilli, organisms, so that reflects something there in the pleural fluid, so that warrants an immediate IC tube. And then the pH, which is a very crucial step, managing the pleural infections. I will come on to that in the next slide. And the proteins, so as we know, the proteins will be high, and we need it to, use the Light's criteria. And then the glucose, if we see very low glucose, that reflects the consumption from the bacteria, and it also reflects parapneumonic effusion of empyema. And LDH, again, if we see very high LDH, particularly around 1,000, so now the BTS guidelines suggests if it is more than 900, it again reflects empyema. And ADA, usually we don't do in parapneumonic effusion because it's gonna high. So ADA has come in two forms, ADA1 and ADA2. So most of the bacterial infection causes high elevation of ADA1. So if we do an ADA for a patient who's coming with parapneumonic effusion, it will always come high. So my message is just see the pleural fluid, and if you see lymphocytic, just go ahead with an ADA. But if you see polymorphs and if you suspect parapneumonic, just don't do the ADA. Right, so the types. Based on the pH and also the parameters, we call it simple, complicated, and complex, complicated. So if the pH is more than 7.2, and if we don't see any organisms in the pleural fluid, we call it simple, uncomplicated. And if the fluid is infected either by culture positive or gram stain positive or pH less than 7.2, we call it complicated. And if you see a complicated pleural infection with loculation, we call it complex, complicated. And if you see gross pus, it's empyema. So this is just a simple diagram coming the evaluation of pleural effusion from the pneumonia, the dry pleurisy, going into the serous fluid with increased vascular permeability and the bacterial translocation, and then leading to oxygen glucose consumption, and then develop into fibrotic exudative phase, and then going into the loculated empyema. Right, so again, same stuff, less than 7.2, it means the significant inflammation, low glucose, bacterial consuming sugar, high pleural fluid LDH, high turnover damaged cells, positive gram stain infected, loculation, fibrin, and pus. So if we don't drain it, it can develop into empyema and fibroprolonged stage. And in the BTS, they strongly mention about like analyzing the pH, and also just be aware about the mimics. So what are the pitfalls? So if you delay to analyze the pH, it will increase the pH of the pleural fluid, and if it get mixed with heparin and local anesthetic, it will lower the pH. So same stuff, less than 7.2, immediately drain. If you see a pleural fluid more than 7.4, just antibiotics. And this is where sometimes like we, need to play a bit of a, because like sometimes we get pleural fluid pH around 7.3, 7.25. So in that case, you just see the patient holistically. So if you see a very high spiking fever with chills, and if you see the ultrasound imaging compatible with complex pleural effusion, just see the LDH. And if you see a high LDH, just see the sugar. And if you see very low sugar, go for IC tube. So basically, pH less than 7.2, IC tube. More than 7.2, either IC tubes, depending on the other parameters, and otherwise just treat. And in most of the instances, we don't have pH to analyze. So in that case, same rule, see clinically, high spiking fever, chills, ultrasound appearance, and see the sugar. If the sugar is very low, treat IC tube. So this is the same thing. I'll just skip. Again, 7.2, high risk developing into complex pleural effusion, IC tube. More than 7.2, 7.4, lower risk, just treat with antibiotics. In between, see the patient, clinical parameters, LDH, sugar, IC tube. Right, so before coming into the treatment arm, I'll just show this diagram again. It's like going from simple pneumonia into the empyema, and initially the exudative phase, going into the fibropurulence phase, and then organizing phase, where in the exudative phase, mainly antibiotics, and in the fibropurulent phase, we do enzymes. Unfortunately, it's not available in our country. And in the organizing phase, we just need to do surgical interventions. Right, so treatment strategy. In BTS, they recommend using this rapid score based on the renal age, presence of pleural fluid, infection source, dietary factors, and risk category, dietary factors. So they categorize the risk. And here, like you can see the presence of pleural fluid. For purulent, they put 0. For non-purulent, they put 1. Because in the BTS, they suggest if you see a gross pus, that indicative of localized collection. So it's very easy to drain. So they put 0 on that. Right? And then antibiotic treatment, as Dr. Sachini mentioned, the most common causative organisms will be Staph and Staph aureus in community acquired. And in hospital acquired, mostly MRSA and Pseudomonas. So in community acquired, same stuff, coambisculav with metronidazole. And then hospital acquired, escalated piptas, carbapenem, or maybe vancomycin if you suspect MRSA. Duration, this is something we need to because most of the time when the patient feel better, they just get discharged. But at least we need to, the patient, they need to be treated for at least 4 to 6 weeks. So initial antibiotics, and then step down to oral, and just send the patient home with oral antibiotics, and review in like either 2 weeks time, 4 weeks, and then as wisely. Pleural drainage. So we all know the indications: frank pus, empyema, positive pleural fluid for microbiology, or the pleural fluid is less than 7.2. And the BTS recommend always go for a small bore chest tube, less than 14 French. Then the intrapleural agents, like in foreign countries, we do fibrinolytics and also enzymes. So the usual dose is altiplase 10 milligram with DNase 5 milligrams BD for 3 days. and it's a strong consensus. So like it was based on the MIS2 trial, which was done in like 2022 or 2023, and also they also mentioned suggest saline irrigation, so at least 200 ml TDS. That also will reduce the complication and reduce the necessity of surgical interventions. This is again the streptokinase was based on the MIST-1 trial, which was happened in around 2005. But they noted that there was no difference, but they that they had a little bit of increased bleeding with the streptokinase, and we don't practice that. And TPA plus DNase, which is the MIS2 trial, combined TPA, alteplase plus DNase, and it had like clear benefits and improved the reduce the morbidity and mortality, and improves the outcomes. But we have to use both together, right? And also the saline irrigation that prevents the time for surgical interventions. So what about surgical interventions? So it's usually generally reserved for patients who do not respond to medical treatment. So initially antibiotics and drain, and then if it goes to fibrolytic phase, intrapleural enzymes. So we allow the patient, we allow the fibrotic agents to work for like 72 hours. And if we see that there's no response, then that is where we call surgeons. And the timing, I will left it to discuss in the expert panel discussion, and also they do some several procedures where so with the open decortication. And this is a kind of strong consensus, as they mention in the BTS guidelines, due to lack of supporting evidence, early surgical drainage under VATS or thoracotomy should not be considered. So always need to be treated with the IC tube, medical treatment, and then only the surgical interventions. And sometimes, like in subacute stage, we tend to do medical thoracoscopy and do that adherolysis and do some saline irrigation. But also, they say due to lack of supporting evidence, early medical thoracoscopy also should not be considered. This is again the flow chart that I have taken from BTS. So empyema, IC tube, and then you calculate the rapid score, and then see whether there are any other pleural thickening or pleural masses, which we need to call the surgeons. Otherwise, just allow them some time, and then assess if there's a good response, continue antibiotics with the IC tube, and if not, then that's the phase where you treat with antifibrotics and DNase, allow them for another 72 hours. If not responding, call surgeons. If responding, just continue with the same antibiotics or escalate, whatever. And yeah, this is again just I took it from the BTS. It's just so summary. If there's a pocket, do the thoracentesis, uncomplicated with pH more than 7.4, antibiotics, complicated with in the margin, just see the patient holistically, and you can either consult respiratory team or just do it as per the guidelines. Complicated, drain and antibiotics, and CT, pleural fluid evidence of empyema, again drain and antibiotics, loculations of chest X-ray, ultrasound, CT, and you can do 2 chest drains into the large pockets. So in my practice, I usually do I put a one Seldinger into the large pocket and maybe a pigtail into the small one. Or maybe you can consult respiratory or cardiothoracic surgeons. So those are the pictures taken from Google. You can see the pleural fluid, how do we see when we drain the pus, and the thoracoscopic view. And yeah, that's it. Thank you, and yeah, thanks for your patience.
Thank you, sir, for the informative presentation. Our next lecture is on systematic and guideline-based approach to connective tissue disease-associated interstitial lung disease. And it is my pleasure to invite Dr. Arthahai Srirangan, who is a consultant pulmonologist currently attached to the National Hospital of Sri Lanka. Dr. Srirangan completed her MBBS degree from the Faculty of Medicine, University of Sri Javardhanapura, with a distinction in medicine, and subsequently obtained her MD in medicine. Over to you, madam.
Good afternoon, everybody. Thank you for the introduction. My sincere thanks to the CCP and Sri Lanka College of Pulmonologists. Today, I'm going to discuss about the systematic and the guideline-based approach to the CTD-associated ILD based on the two guidelines. One is a 2023 ACR and the CHEST, and the ERS and EULA guideline, which is in the 2025. Before starting, I just want to highlight a case which we have managed when I was doing the overseas training. It's a 50-year-old woman initially presented with worsening shortness of breath with a MMRC of 2 on the background of dermatomyositis. Her CPK level was normal and the autoimmune screen has shown MDA5 autoantibodies positive with a DLC of 42% and FEC was 91% with normal echo with troponin negative. And this is the first CT which shows OP with NSIP pattern. And she was started on tapering dose of steroid and maintained on tacrolimus 2.5 milligram BD. She was gradually improved and back to work without any oxygen requirement to her baseline. After 4 months of initial presentation, she was admitted with worsening shortness of breath. Patient treated with combination of IV methylprednisolone, plasma exchange and IV cyclophosphamide and IV immunoglobulin. And she was followed up by rituximab, MAP and tacrolimus and very slow corticosteroid tapering. We'll discuss this case, the rationale of the treatment with a guideline base. So why the ILD is a major impact on CTD survival. If you see this graph on the left, you can see over the year in the systemic sclerosis patient, major cause for mortality is the pulmonary fibrosis. And this also on the right-hand side, you can see the patient with RA-ILD compared to the rheumatoid arthritis alone, the mortality was high. So it's a early detection of ILD in these patients will help us to treat them for the better prognosis and the better mortality for this patient. So who to screen and what are the screening tools we'll discuss. The both guideline agrees HRCT CHEST is the most appropriate test to screen for the ILD because in asymptomatic HRCT abnormalities present up to 50% at risk patient before the clinical symptoms develop. And both guideline agree the pulmonary function tests are the key to be used for monitoring with DLCO and the spirometry value. And why the lung function is not a good for the assess the severity because the FEC, there's a risk of missing the significant ILD or sometimes overestimate due to the wide normal value. And the DLC also affected by the pulmonary vasculature. That's why we need a screening with HRCT which can give the extent of the disease also. And who to screen? And the ACR guideline give the patient with systemic sclerosis and idiopathic inflammatory myopathy and MCCD, most patients should screen for the ILD. But the EULA guideline, which give a precise recommendation, they strongly recommend all the patient with systemic sclerosis and mixed connective tissue and patient with idiopathic inflammatory myopathy with a risk factor should be screened with the HRCT. And they conditional recommendation for patient with IMM without risk factors and the rheumatoid arthritis and Sjogren with risk factors should screen for the HRCT. So what are these risk factors? So the risk factor for developing ILD in these patients divided into group of demographic, circulating markers and the extrapulmonary. So on summary, if the patient is old age, male sex, and if the circulating markers such as increased inflammatory markers like CRP and the ESR high with the positive autoimmune screening like rheumatoid factor, anti-CCP, and if they have anti-JO, MDA5, anti-RO52, those with active skin diseases like diffuse cutaneous with arthritis and skin involvement, these are the extrapulmonary. If they have a high risk for progression to ILD. So once we diagnose patient with CTD with ILD,
we need to do some basic investigation if we suspect any alternative diagnosis. Because if there can be we need to consider bar to rule out the infection or like malignancy, which like low-grade lymphoma or alveolar hemorrhages. At the same time, we need to assess the prognosis and risk of progression and risk of development of severe disease. It's based on the patient's clinical risk factors, and we need to see the lung function with DSU and FEC, with HRCT pattern and the extent, and the 6-minute walk test with any auto desaturation. These are we need to do at the diagnosis. So how frequently we are going to monitor? So again, the ACR give like every 3 to 6 months for the first year, then less frequent, one stable. But again, the EULA guideline give more precise. We need to risk stratification of this patient with the lung function, HRCT, and the inflammatory marker, and divide the patient into 2, high risk and the low risk. If high risk, we need to do the lung function every 3 to 6 months in the first year, followed by 6 to 12 months thereafter. And the low risk, we can go for 6 to 12 months initially, then yearly one stable. And HRCT shares for the high-risk patient or risk of progression suspected, we need to do every 1 to 2 years. But in patient with idiopathic inflammatory myopathy, we should repeat it 3 to 6 months because they have a high chance of going into severe and rapid progression. But we need to decide on patient's symptoms and other profile also. So before discussing regarding the treatment option, I just want to give some randomized control trial which they base for the treatment. So this SLS2 trial have shown the mycophenolate is effective as cyclophosphamide with a fewer adverse effect profile. And the Fascinate and the Focus trial has proved in the systemic sclerosis patient, tocilizumab for patient with early disease or diffuse cutaneous symptoms and increased inflammatory markers, the tocilizumab is a first line. We can use it like that. And the rituximab also shown benefit. And there's a residual trial which shows the SRRD ILD, all the ILD disease with CTD ILD. Rituximab have shown superior to the effective in controlling the progression of the disease. And if the patient is NSIP, they have shown the ILD studies have shown rituximab and MMF is compared superior to the MMF alone. And this is also evidence of the antifibrotic for systemic sclerosis, the nintedanib in the census trial, and RA-ILD with UIP pattern. The trial shows the perfenidone is it's better. And this is the inbuilt study which shows the nintedanib is better in the patient with progressive pulmonary fibrosis, which means the FEC drop more than 10% in the more than 10% in that within the 24 months, or it's with the symptoms and the HRCT changes with the FCC is 5 to 10% loss. And this is the new trial in the phase 3 nerolimus, which is ongoing for the progressive pulmonary fibrosis. So again, the ACR is a first-line therapy for the connective tissue disorder. All connective tissue disorder, they have recommended mycophenolate. And as we discussed, according to the Fascinate and the trial, the tocilizumab, they have recommended for the second line. This is like a head-to-head in the hierarchy order. So they have and for the cyclophosphamide, they have put it in the additional option. And the glucocorticoids also, they have strongly recommended against for the systemic sclerosis, and others only for the short term, which means 3 months or less. And again, if it's progressing, then we can switch to other therapies. Like if the patient, when the mycophenolate progress, we can optimize the treatment, or we can go for the rituximab. And if they meet the pulmonary progressing fibrosis, then we can go for the antifibrotic drug. And for the systemic sclerosis, they also recommended stem cell transplant for those patients. And myositis, they also recommend JAK inhibitors also. So this is again the EULA guideline for the systemic sclerosis. Again, they have strongly recommended tocilizumab for the ILD with extrapulmonary involvement or early diffuse systemic sclerosis more than mycophenolate. And if the patient is having a fibrosis more than 10% without any extrapulmonary, they'll recommending nintedanib. And if the high risk of progression, then we can combination of the immunotherapy or can go at the nintedanib if criteria is fulfilling. And if it's severe multi-organ failure, we can go for the cyclophosphamide rituximab. And again, for the RA-ILD, they divide into two groups. One is with active arthritis, one is with a well-controlled arthritis. Active arthritis, they have recommended abatacept, rituximab and JAK inhibitor. RA-ILD with well-controlled arthritis, with severe progressive ILD, we can go for the combination. If having a progressive pulmonary fibrosis, then we can add the nintedanib. And if the patient is well-controlled arthritis and having the UIP pattern only, we can go for the pirfenidone for the first-line treatment. And if we go to the idiopathic inflammatory myopathies, all patients, they strongly recommend for the immunosuppressive treatment, like glucocorticoids and calcineurin inhibitors, because they have, like tacrolimus, they have found it's a rapid action and low cost. So they recommended calcineurin tacrolimus for the first-line treatment, other than mycophenolate and azathioprine over it. And if the high risk of progression, then we can go for the combination, like high-dose glucocorticoids and cyclophosphamide or rituximab. If having progressive pulmonary fibrosis, again the nintedanib. And if the patient is having a rapidly progressive, there's a difference between the progressive pulmonary fibrosis and the rapidly progressive. The rapidly progressive means over the week or few months, the patient is progressed. So this patient, we can go for the triple therapy, and we can add like IVIG. If having an infectious risk, then we can go for the IVIG and the plasmapheresis. Even though they have, this is a usual clinical practice, they didn't recommend it because there is a risk of, it's not available in all the centers. So some difference in the treatment recommendation. Pirfenidone, in EULA, they have mentioned the first-line treatment for the RA-UIP. But in CHEST, they have mentioned only for the progressing RA-ILD. And MMF and nintedanib combination, the EULA recommended as a first line, but ACR is against it. And the JAK inhibitors, such as tofacitinib, the first line option for the idiopathic inflammatory myopathies, but the EULA is recommending, if it rapidly progressive, those patients, they have recommending it. And the ACR recommending stopping glucocorticoids within the 3 months in SARD-ILD, but EULA doesn't state it. And the ACR also recommended conditional against the methotrexate, leflunomide, and TNF-alpha inhibitors and abatacept in RA-ILD and Sjogren disease. And after, again, we'll go to our initial case. So our patient, which was the treatment option, so according to the ACR, because the patient having a rapidly progressive ILD, so we have treated with the IV glucocorticoids and 2 additional therapies such as cyclophosphamide and IVIG. And it also, if you see in the same EULA, so rapidly progressive, so it's a combination therapy we have given in this case. So, if the ILD is progressing despite the immunosuppressive treatment, how do we know whether to intensify the treatment or combining the treatment, whether to introduce the antifibrotic therapy or continue the immunomodulation or stopping the immunomodulation? This will depend on these factors. So, when consider increasing the immunosuppression, if the morphology is suggestive of inflammatory component, and if antisynthetase MTA5 idiopathic inflammatory myopathy, and having extrapulmonary inflammation and previous response to increased anti-inflammatory treatment. And consider reducing if there is any or stopping even if advanced fibrotic CTD-ILD with extensive honeycombing, extensive traction bronchiectasis, or in elderly with frail patient or recurrent infection. These all depend on patient wish, and so we need to take a decision case by case. So in conclusion, so the guidelines and clinical expert agree that immunosuppression is the first line treatment in the most SARD-ILD. If immunosuppression may not be effective or may less effective in patient with UIP pattern, particularly in RA-UIP, so consider upfront treatment with a pirfenidone. Upfront combination of corticosteroids and at least 2, like a triple therapy in patient with rapidly progressive ILD, which we are seeing with the idiopathic inflammatory myopathy with MDA5 antibodies. And nintedanib alone or with the MMF is a first-line treatment for the systemic sclerosis ILD, but we need to select the patient correctly. And when progression occur, initial immunosuppression, we should consider increasing it or adding other one. And if the progression is of lung fibrosis occur, we can introduce the antifibrotic treatment. But in some cases, we need to stop or avoid immunosuppression also.
Thank you, madam, for that valuable and informative lecture. We now proceed to the fourth lecture titled Non-Cystic Fibrosis Bronchiectasis, Evolving Concepts and Clinical Strategies by Dr. Niranjan Chandramal. Dr. Niranjan Chandramal is a consultant pulmonologist currently attached to the District General Hospital in Vaunia. He completed his MBBS degree from the Faculty of Medicine, University of Peradeniya, and obtained his MD in Medicine from the University of Colombo. Please welcome Dr. Niranjan Chandramal.
Hi, good afternoon, everyone. And first of all, I would like to thank Ceylon College of Physicians for giving me this opportunity and for the Sri Lanka College of Pulmonology. Right. So in this next 15 minutes, I would like to speak about evolving concepts and clinical strategies about non-cystic fibrosis bronchiectasis. So starting with a case, it's a real case from Vaunia. 33-year-old unmarried shop assistant, previously not evaluated, but she has a history of rhinitis and sinusitis since childhood. Present with 2 months, for the last 2 years, she's having increased productive cough and some increased mucopurulent sputum production with recurrent lower respiratory tract infections and tinge hemoptysis time to time, constitutional symptoms, but no past history of tuberculosis, no connective tissue disease features, and she's a product of a consanguinity. And on examination, no mild respiratory distress, and there's coarse crackles in mid and lower zones in the lung bases, no features of pulmonary hypertension. All the inflammatory markers on high side. So after 2 courses of antibiotics, CRP coming down from 87 to 23, and sputum repeatedly positive for coliform, but pan sensitive, but all the TB workup is negative. So in the medical ward, patient was treated twice with antibiotics. Once patient treated with IV antibiotic, but when the CRP come down, so they have given the inward physiotherapy and then they discharge with a LABA-ICS inhaler. But when she come to the respiratory clinic, she has no significant change in her sputum volume, or she's having very purulent sputum, producing large volume, having hemoptysis and the very thick secretions, and she's having some difficulty to perform ADL as well. So when I go to this history, so the questions that I have is, are we managing this bronchiectasis completely? My answer is no, there are more things we have to do. And have we evaluated this patient completely? Because there are some treatable traits in bronchiectasis, so patients should be evaluated thoroughly, especially patients with young bronchiectasis that is less than 50 years old. And will she develop progressive lung damage due to bronchiectasis? Unless if she has appropriate treatment. And can we add any additional treatment steps to improve her symptoms? Definitely yes. That's what I'm going to discuss in my in this presentation. So bronchiectasis is it's a bit of neglected disease because there's no like ongoing like definite treatment, like even a WHO definition, but you can't neglect the effect and the burden it gives to the individual and the healthcare system. So as a definition, I can say it's a chronic suppurative lung disease characterized by irreversible airway dilatation, recurrent infection, and frequent exacerbation, which can contribute to progressive lung function decline and reduce quality of life. And that not only affect the mortality and morbidity, it will increase the disability adjusted life years, we call DALY, and the prolonged antibiotic courses and the recurrent hospitalization, which will give rise massive burden to the healthcare system. So previously we discussed the pathogenesis of the bronchiectasis as a vicious circle, because we thought infection causing inflammation, which is causing some like a dysfunctional epithelium, and then this lead to the lung damage. So if we try to break at one point this circle, we can manage bronchiectasis. Now we know that all these infection, inflammation, dysfunctional epithelium, and lung damage, those 4 components are interrelated. So if you want to manage bronchiectasis, you should address each and every component. So it's like a vortex. That's why the current concept going as it's as a vicious vortex. So if you want to evaluate bronchiectasis, there are different domains. Still 40% are idiopathic. But in Sri Lankan context, you have to think more about the infection, especially post-tuberculous disease, NTM fungal infections. And most of the patients coming with childhood infections. There are some causes due to impaired host defenses, especially think of primary immunodeficiency disorders. In comparison of cystic fibrosis and primary ciliary dyskinesia, we are more prevalent to have PCDs, but still there are CF I think cases we find when we do the investigations, and it can be associated with allergic and autoimmune causes like inflammatory bowel disease, rheumatoid arthritis, and other connective tissue diseases, and especially when we are investigating patients for a poorly controlled asthma like ABPA. And especially when there's a localized bronchiectasis, you have to think about inhaled foreign body or like a bronchial carcinoma, and some obstructive lung diseases like COPD and asthma. And again, if there's early emphysema, you have to think of some of the congenital conditions like alpha-1 antitrypsin deficiency and some bronchial tree malformation. And especially now we are going to the era of transplant. So after the transplant also, now there are cases developing with the bronchiectasis, and sometimes you have to think about some features of cases of chronic aspiration as well. So in the BTS 2019 guideline, they said for the healthy individuals who is having productive cough more than 8 weeks should investigate for the bronchiectasis. And there are patients who are having high risk factors with productive cough. That means rheumatoid arthritis patients, COPD with recurrent exacerbations or previously culture positive for Pseudomonas aeruginosa, patients with inflammatory bowel disease, poorly controlled asthma patients, and patients with immunodeficiency disorders or who are on immunosuppressive therapies, or chronic rhinosinusitis, chronic GORD, and underlying connective tissue disorders. Patients coming with productive cough or recurrent infections, that patient should investigate for a bronchiectasis. So the diagnosis-wise, you should perform a baseline chest X-ray, but to confirm that, you have to do a HRCT chest. So in the right lower corner, you can see it's ongoing. You can see our case patients the HRCT chest, and there are some few defining things you can see in the HRCT. One thing is about the signet ring signs. We call there's an increase the size ratio between the bronchial lumen and the adjacent pulmonary artery, and the lack of tapering. And there is a visibility of dilated airways in the most peripheral parts of the lung. So if you see that, you can identify the bronchiectasis. But sometimes there are very minimal features with some kind of features like high disease severity, disease activity like bronchial wall thickening and mucus impaction or mosaic attenuation in the expiratory CT. Right. So in this slide, the ERS guideline recommend every patient of bronchiectasis should investigate for the treatable traits. That means you have to do a full blood count, you have to do a total immunoglobulin panel, and check if the immunoglobulin level is high, you have to do a serum electrophoresis, and you have to check for the aspergillus-specific IgE and IgG and the total IgE for the allergic panel, and you have to exclude NTM with the TB culture. And according to the patient characteristics, then you have to decide on the other investigation. So if there's an early onset disease with chronic rhinosinusitis, you have to think of PCD or like a CF. And if it is a localized bronchiectasis, again, go for a bronchoscopy and check whether there's any foreign body or a tumor, or then obtain sample for the non-TB mycobacterial. If there are systemic symptoms, then you have to investigate for underlying connective tissue diseases. Early emphysema, then again think of alpha-1 antitrypsin deficiency. And some recurrent infections, you have to think of immunological side, do immunology referral, and think about underlying immunodeficiencies as well. Right. So, and every patient should assess the severity and the activity of the disease. So, the severity assessment should do by a bronchiectasis severity index score, and which will give you some future idea about what is the mortality and hospitalization of the patient. So I need to, most of the time, cover all the exacerbations and the colonizations as well. but but you have to have some idea about what is the disease activity, which can't cover from the severity index. So then you have to do assess about the sputum burden, sputum volume, consistency, whether there's any hemoptysis or any mucus plugs in the CT, and the inflammatory markers as well. So in our case, so the HRCT now it was confirmed as the bronchiectasis. There are some mucus plugging, but all the treatable trait investigations are negative, aspergillus, immunoglobulin, and sputum. FEV1 is 53%. So overall, so this is like a high severe, because the BSI grade is more than 10. So the high severe grade bronchiectasis with a high disease activity. And you can see the bilateral sinusitis as well. So early onset disease. So probably this may be ongoing primary ciliary disc kinesia. So the treatment, there are 4 goals in the treatment. 2 things we want to improve symptoms and improve quality of life. And we want to prevent exacerbation and prevent disease progression. So you can see in my first previously mentioned the vicious word vortex. So you have to do your management to cover each and every component. So in the recommendation, what they said, the patient education and self-management plan recommended, because you should involve the patient into your management. They should know about what is their disease. They should know what they have to do during exacerbation. They should know how to take the rescue antibiotic pack. And it's a strong recommendation. Patients should be taught airway clearance technique. If the clearance has failed, if the airway clearance have failed, we should offer mucolytics. And for the high-risk exacerbation patients, that means more than 2 exacerbation or 1 severe exacerbation, or there are daily sputum burden, that patients, you should have long-term inhaled antibiotics like polystine, oral like gentamicin, even they are having a pseudomonas or not. So that is strongly recommended. And in the absence of inhaled antibiotic, you can go for a long-term macrolide like azithromycin 250 milligram, like 3 times per week. But you can't use the other antibiotic as the first line antibiotic because of the drug resistance. But if there's a new isolation of Pseudomonas aeruginosa, definitely you should offer eradication treatment. I will discuss it a little bit later. And if there is a patient with breathlessness and impaired exercise tolerance, there's a strong recommendation to go for a pulmonary rehabilitations. And for any chronic lung disease, you should offer annual influenza and the pneumococcal vaccination in their lifetime. But the other thing is, don't offer long-term inhaled corticosteroids or systemic corticosteroids unless the patient having COPD, asthma, or any other indication for a steroid. And I told patients should taught about airway clearance. So there are nothing superior from one to another. So you can go for active cycle breathing techniques or positional breathing techniques, or otherwise you can use some devices for the good adherence. So this is in the right side. You can see one of the information leaflet I made for the patients, and the other device is a Aerobica device which we use as a for the assistance for airway clearance. And there should be a specific sequence for the airway clearance. So the patient should start from the bronchodilator, then go for their mucolytics with the nebulized with normal saline. Then they should do their airway clearance. Then if they are using an inhaled antibiotic, they have to use that. So they have to use this sequence. It will help for the more effective treatment, and it will help for the prevent bronchospasm due to some inhaled antibiotic. And you can see with this meta-analysis, Pseudomonas can cause high mortality, high morbidity, and high risk of exacerbation. So if you isolated Pseudomonas, you should hit hard. So you have to go for eradication therapy. That means sometimes oral antibiotic 2 weeks, or go for anti-Pseudomonal antibiotic for 2 weeks, followed by 3 months of nebulized antibiotic, most probably a polystine or maybe a gentamicin. Right. So a few points about management of exacerbation. It's the worsening of symptoms exceed day-to-day variability and which requires change in management. Few things I want to highlight is, please obtain a sputum sample even they have previous sputum results during their exacerbation. And your antibiotics should be guided by previous microbiology results and the susceptibility pattern. And for the severe exacerbation, all the patients with Pseudomonas, you have to go for 14 days of antibiotic, or for the mild bronchitis, you can go for a shorter courses. But you have to adapt their airway clearance involving physiotherapy team. Right, for the rapidly deteriorating patients, so there is an algorithm. So again, it comes into the 5 component. R means recognize the deteriorating patient and assess them from their history, their airway clearance, and identify whether they are developing new comorbidities or whether they have any treatable traits. Then you perform the review of airway clearance, perform a new HRCT chest, do a new sputum to identify bacteria, fungal or mycobacteria. If they are not producing much sputum, go ahead with a bronchoscopy, and then check for underlying ABPA or any other NTM disease, and go for a lung function test, and they initiate the antibiotics, or if it is a pseudomonas, go for eradication therapy and go for a targeted treatments, and update there from the airway strategies. And the most important things about the deal with complication, then you need the multidisciplinary approach. For the malnutrition, you have to liaise with your nutrition. Hemoptysis is very important, so you have to go with the medical management. Then you have to liaise with your interventional radiologist for bronchial artery embolization. But for the localized bronchiectasis, again, there is a place from thoracic surgical approach as well. And if there's a respiratory failure, then you have to go with the oxygen, non-invasive ventilation, and when available, referral for lung transplantation. Or if the patient is not in that situation, go for a palliative approach. For the case outcome, so the patient treated again in the 10 days with the IV piperacillin tazobactam with some regular chest physiotherapy. Patient was taught ACBT and review her sessions, add some mucolytics, and after IV antibiotic, we plan for a macrolides as a continuation at least for probably up to 3 months to 1 year time, and shared care with ENT and nutrition teams. And we stop lab ICS because there's no asthma or COPD in that patient. And at discharge, patient having a reduced sputum burden. So we are going to now monitor this patient in our clinics and plan for a vaccination and in the future, inhaled antibiotics. Few points about the novel strategies, because now there are some definite treatments are on the way. So there is a FDA approved drug called brensocatib, which will help for control the neutrophilic inflammation. And in Georgia, there are some good studies about bacteriophage therapy as well. So I think the take-home message is, so when you are finding a bronchiectasis, don't stop with antibiotic and invert physiotherapy. You have to continue antibiotic, and you have to go with the long-term plan to prevent the disease progression and prevent the future exacerbations. Thank you.
Thank you, sir, for your presentation. Next up is a presentation on practical approach to co-pulmonale by Dr. R. Manmathan. Dr. Manmathan is a consultant pulmonologist currently attached to the teaching hospital Batik. He completed his MBBS degree at the Faculty of Medicine, Eastern University, Sri Lanka, and later obtained his MD in Medicine from the University of Colombo. I now invite Dr. R. Manmathan on stage.
Good afternoon, everyone. First of all, I would like to thank the Ceylon College of Physicians and College of Pulmonologists to give this opportunity to talk on this topic. So it's a great honor to be here in front of this esteemed audience. And my talk, next 12 to 15 minutes, I'll be discussing about right heart in lung disease, a practical approach to co-pulmonale. So today I'm going to cover a case, and starting with a case and the introduction and definition of co-pulmonale and etiology and pathophysiology and evaluation and how are we going to manage. So this is a common case scenario. So we encounter day-to-day practice, clinical practice. So my patient is a 65-year-old a lorry driver who came. It's a current smoker as well, and he presented with a progressive breathlessness for last 3 months durations with MMRC scores 2 to 3, associated with a bilateral leg swelling. And he also complained of mild productive cough with whitish phlegm and no history of fever or continuous symptoms. On examinations, there was a few bilateral bronchi and saturation was 85% on air. And he's mildly tachypneic with a respiratory rate of 20, and there was a bilateral pedal edema and elevated JVP. So this is the patient's chest X-ray. You can appreciate there's a hyperinflated and the narrow mediastinum with a flattened diaphragm, which is suggestive of COPD. And the basic blood investigation showed the full blood count, liver profile, and renal profile and albumin were in the normal range. And ABG, the pH is normal, and PCO2 is high, 65 millimeter mercury, bicarbonate high, and PO2 is 45 millimeter mercury. So it is a chronic type 2 respiratory failure, which is compensated, and CRP is slightly elevated, and ECG showed there's a P pulmonale, and 2D echo revealed moderate to severe pulmonary hypertension with normal ejection fraction. And spirometry in the previous record revealed the obstructive airway disease without significant bronchodilator reversibility. So this is a simple case of like exacerbation of probably we have treated as an exacerbation of COPD. Started with some antibiotic and nebulization and course of steroids. And the second day, the patients clinically feel better and saturation around 91% on 2 liters of oxygen. So, so are we going to stop there, or like are we going to do some more things regarding the patient's management? So, what about are we thinking of any starting oxygen therapy or long-term oxygen therapy? And what's the place of diuretics, and how are we going to proceed with that? And what is the place of anti-pulmonary hypertensive medications, bosentan or sildenafil? So, copulmonale. So, what is copulmonale? This is a Latin term introduced in 19th century. Co means heart, and the pulmonary means the lungs. So, it's a pulmonary heart. So, what is the definition? It is an abnormality in the structures and functions of the right heart, mainly due to the lung disease, and it is associated with renal detention of salt and water, and it is unlikely due to left heart disease or congenital heart disease. So this definition is derived from the NICE guidelines. So etiology, when you look at the etiology, COPD plays the most important part, more than 50%, and also some other chronic lung diseases like interstitial lung disease and bronchiectasis, and neuromuscular disease, obstructive sleep apnea, pulmonary artery hypertension, and chronic thromboembolic pulmonary hypertension. So when you look at the pathophysiology, so the starting triggering point is the hypoxemia. So hypoxemia due to the COPD or other lung diseases, which can cause the vasoconstriction. And you have to remember, so in systemic circulations, the hypoxemia causing vasodilatations to improve the oxygenations or tissue perfusion of oxygenations. But in pulmonary circulations, it will cause vasoconstrictions for the hypoxia to divert the blood supply for the ventilated area. So that is the important pathophysiology here. And the chronic hypoxia causing chronic vasoconstrictions resulting in a vascular remodeling, and it will increase the pulmonary arterial pressure, and subsequently the load goes to the right ventricle, and it become hypertrophy, dilatations. Ultimately, its failure can occur. So this is the pathophysiology. So you can summarize. So it's hypoxia, vasoconstrictions, vascular remodeling, pulmonary hypertension, and right ventricular hypertrophy and dilatations. Finally, that is the copulmonale. So what will happen if there's a right ventricular failure? That will the right ventricular outflow will be reduced, and automatically the left ventricular filling will be reduced, and the reduced left ventricular outflow. Subsequently, the right coronary artery gets less blood supply, which is the branch of the that aorta, which is normally supply the right ventricle. Again, it causes the right ventricular ischemia. Finally, again go to the right ventricular failure. So it's a vicious cycles causing the right ventricular of failure or copulmonale. And if you look at the clinical presentations, so they can present with mainly the shortness of breath, either due to the lung pathology or could be due to the pulmonary hypertension. They can get the chest pain because of the right ventricular ischemia or like pulmonary stretching of pulmonary arteries. They can have right hypochondrial pain because of the hepatic congestions and the leg swelling. So interestingly, the leg swelling, the pathology behind this, it could be due to the venous congestion. At the same time, this hypoxemia and chronic hypercapnia activate the RAS systems, the renin-angiotensin-aldosterone system, and increase ADH in the blood. So it will promote the absorption of sodium and water in the kidney in the proximal tubules, that ultimately causing the leg edema. And also it can cause the tachypnea, hypoxia, and elevated JVP pulsatile levels, and a lot of murmurs, like there's early diastolic murmur because of PR, or like a pansystolic murmur because of the TR. So what are the investigations? So the X-ray is very, very important. So you can get an idea about that lung fibrosis, or like bronchiectasis or COPD, and ABG is very useful for the prognostications, and also to guide you for the treatment. And ECG, you can get some P pulmonale or evidence of like right ventricular strain or right ventricular hypertrophy. And the 2D echo is a very useful non-invasive test to identify the pulmonary hypertension or right ventricular dilatation and right ventricular hypertrophy. And still the right cardiac catheterizations, which is the gold standard of investigations to confirm the pulmonary hypertension and copulmonale. And other imagings we can do, like cardiac MRI, HRCT, chest, and CTP and VQ scan to identify the underlying lung problem. So how are we going to manage? So we know the most important, the problem here is the lung. So we need to manage the lung problem, primary lung conditions. Like in our patients, the COPD is the problem. So we need to treat with the steroids, antibiotic, and nebulizations or inhalers. And what about oxygens and diuretics? So oxygen, I would say, like, it's a very, very useful medications that is known to improve the mortality of patients with a persistent severe resting hypoxia. These studies are well validated in COPD patients. So I would like to touch on that's two landmark trials which was done in 1980s. So first one is the NOT trials, and the second one is the MRC trials. In the NOT trials, they have involved around 203 patients and with a persistent severe resting hypoxia, and all are COPD patients, and half of them given continuous oxygen support, and half of them given a nocturnal oxygen therapy only. So at the end of 1 year, so they noticed there was an improved mortality in the continuous oxygen group. And the next trial is the MRC trial. So this is a British trial, so involving 87 patients. There also the half of the patients given the oxygen 15 hours of oxygen, and then half of the patients, the control, there's no oxygen. So they have evaluated at the end of 1 and 5 years, and they also noticed there's an improved mortality in the oxygen groups. Then only they have changed, all the guidelines changed to give start LTOT, not only the COPD patients and all the patients with chronic lung conditions. And another studies has been done in 2009 to 2014. So they have selected the patients with a COPD with a moderate desaturation. That is not that the previous criteria. So this is 89 to 93% of saturations, and also nocturnal desaturation and exertional desaturation. Those group of patients, they have given like 24 of oxygens and or as needed oxygen, especially exertional desaturations. But the results didn't show some significant benefit in the oxygen groups. So that's why they're still not recommending to give oxygen therapy for the moderate desaturation. And what about the diuretics? The diuretics still there is no robust evidence, no RCTs, but a few observational studies and the expertise opinions we can give for some symptomatic relief still need to be given with a cautions. Because why? So you can recall with our pathophysiology. So in right ventricular failure, or it automatically causes the left ventricular output also reduced. So in that case, if you over diuresis, that will deplete the intravascular volume, again causing the more problems. And what about the sildenafil and bosentan? So these are the anti-pulmonary hypertensive medications mainly useful. But in our case scenario, so what is the use? So if you look at the go back to your pathophysiology. So in hypoxia, in our pulmonary hypertension causing vasoconstrictions. So if you alleviate the vasoconstrictions, there was a like abnormal or vasodilatation can occur. Sometimes it can improve, it can worsen the VQ mismatch. So that's why the conditions or like patient's outcome can be worse than the normally as we are expected. So other management aspects, the smoking cessation are useful, and vaccinations and pulmonary rehabilitation and salt and fluid moderation as for all the chronic lung diseases. So in our patients, how are we going to proceed with our patients? So the place of LTOT, of course, we have to think about, but still, so we have to observe for is there any persistent resting hypoxia. So in the secondary patient clinically improve, so our plan is to like reduce the like oxygen, and we can send the patient home, and after like 3 weeks we can repeat the blood gas of the patients if the PO2 is less than 55 millimeter mercury, or like in our patients, like even if it's a 55 to 59 millimeter mercury, as there is a like evidence of primary hypertension or copulmonale, so we can consider about the long-term oxygen therapy. And diuretics, what about diuretics? Again, yeah, we can use this but with cautions. And bosentan, sildenafil, so definitely we can't use, especially in our patients. So it is not useful unless if our patient is having a pulmonary artery hypertension or severity of the pulmonary hypertension is disproportionately high compared to the underlying lung disease. You can try. So my take-home message is the copulmonale is not involving only the lung, only the heart, so the kidney also involving. And we need to carefully assess the oxygen or LTOT therapy. And you have to diuresis with cautions, and don't blindly start antipulmonary hypertensive treatment. So I would like to end my talk. The lungs write the story, but the heart bears the burden. So thank you for your kind attention. Thanks.
Thank you, Dr. Monmathan, for your presentation. Next up on this specialty update is the expert panel discussion. Before we commence the panel discussion, we will present the token of appreciation to our resource persons today. I would now like to invite the President of the Ceylon College of Physicians, Professor Namal Vijay Singha, to present the token of appreciation. I would now like to invite Dr. Sachini Senaviratna to receive her token of appreciation. Dr. Chandana Dahanayaka, please come on stage to receive your token of appreciation. I now invite Dr. Arthahai Srirangan to receive her token of appreciation. I now invite Dr. Niranjan Chanjaman to receive his token of appreciation. I now invite Dr. Monmathan to receive his token of appreciation. Thank you, sir.
So before I leave, I must thank the College of Pulmonology, especially the President, Dr. Andagale, and senior consultants like Dr. Amithavanand and especially Niranjan to organizing this event. And also I want to make sure that all these young respiratory officials who presented today are members of the CCP. If you have not taken the full membership, please do it today. Dr. Niranjan will organize that. The importance is in 8 years you are eligible for fellowship. Oftentimes we find that when you apply, you have not taken the full membership. Please do so today. Thank you.
Thank you, sir. We now come to the final and highly anticipated session of today's program, an expert panel discussion on the latest guideline-based management of common respiratory diseases. This interactive discussion will provide valuable practical insights into the current evidence-based management approaches for the commonly encountered respiratory conditions. We invite the audience to also engage in the discussion by asking any questions you may have. The session will be moderated by Dr. Niranjan Dissanayake, consultant pulmonologist attached to the Teaching Hospital and District Chest Clinic, Kalutara. And Dr. Niranjan Dissanayake completed his MBBS degree at the Faculty of Medicine, University of Peradeniya, and he obtained his MD in Medicine from the University of Colombo in 2009. He's a council member of the Ceylon College of Physicians, and he's also a past president of the Sri Lanka College of Pulmonologists. Over to you, sir.
Thank you very much. I'm really happy and proud to hear the excellent 5 lectures done by our young respiratory statisticians. And it is indeed a pleasure to moderate this session with some exceptional individuals and professionals from various specialities. And that is how we pulmonologists like to work. We would like to give the best to our patients by involving all specialties involved so that the patient's outcome will be the best. So may I invite the following panelists to the stage respectively. Dr. Dhammika Rasnayaka, a consultant thoracic surgeon at National Hospital for Respiratory Diseases from Välistära. Dr. Saman Kapilawansa, consultant pulmonologist at Teaching Hospital, Ratnapura. Dr. Afla Sadikin, consultant pulmonologist at National Hospital of Sri Lanka. Dr. Sampath Vithanawasam, consultant interventional and clinical cardiologist, currently attached to National Hospital of Sri Lanka with a special interest in pulmonary hypertension, and is a member of the Pulmonary Hypertension Task Force Sri Lanka. And then we have Dr. Tanushka Karunaratne, consultant rheumatologist and rehabilitation with a special interest in connective tissue disorders, interstitial lung disease from District General Hospital, Avisthavella. Dr. Samanmali Gunasekara, consultant microbiologist attached to National Hospital Cancer Institute of Maharagama, who will be briefing out with the novel diagnostics of with the microbiological assessment. And yes, so we'll start our discussion after the chair arrives. Right. So we have 45 minutes for the panel discussion, and we'll try to focus our main discussion regarding how we actually got through and went through the international guidelines and the international standards that are expected when we are managing these patients with certain respiratory diseases. But as we know, demographically, we are different from the European population. Our etiologies will be different. Our problems will be different. Our facilities will be different. So it is always best to know the standard and to see how we can apply it in our current setting. So that is how we are planning to make this discussion forward. So please, the audience, you can raise any questions, and the panelists will also be able to raise any questions. And may I kindly ask the speakers to come to the front. So some of the questions will be to the speakers as well, if all right. So then we can be able to, have a very lively discussion. The only thing is I would love to have the speakers on as well, but there might not be enough space. So yes, speakers as well. Thank you very much. Right. So I think the first was a brilliant lecture by Sachini on pneumonia, Afla. And I think she went through most of the very important aspects of managing pneumonia. Now, when we look at the clinical context in Sri Lanka, now in your clinical experience as a senior pulmonologist, what is the clinical presentation that you will get in pneumonia? And what are the possible underlying etiologies that you have dealt with, especially in patients with severe pneumonia?
Thank you very much. First of all, I want to thank the College of Pulmonologists and the
College of Physicians for giving me this opportunity. Yes, Niranjan. So you have a very important question to ask to start the session. So now, when we see cases in severe community-acquired pneumonia, so most of those patients are managed in the ward setup, and of course we are called into the ICU setup for those patients. And when we attend or when we encounter those patients, most of these patients are having evidence of a bacterial infection. So, but having said that, if you look back and if you go through their profile, especially the history and the clinical context, I think it is more there's a quite a number of patients who are having a viral infection preceded with the secondary bacterial infection. And on top of that, we have some degree of amount of patients who are having underlying lung disease or with some comorbidities, having this community-acquired pneumonia. We have labeled them as community-acquired pneumonia, and those patients are with severe pneumonia. So if you look at the demographic or the clinical context, yes, the severe pneumonias are more with the bacterial infection, but nevertheless, simple viral pneumonia in a tertiary center or in a severe pneumonia setup is always complicated with bacterial pneumonia.
Now, I think Sachini raised a very important question where, so sometimes we have ways of identifying bacterial infections, but sometimes the ways of identifying atypical infections are less. So do we have currently ways of identifying Legionella according to the guidelines setup, and how can we approach that if a clinician is suspecting Legionella or atypical pneumonias? Yep.
Yes, identifying typical pathogen is always easy because those typical pathogens will grow on our culture media, but identifying atypical pathogens and viruses are difficult. For the viruses, we have antigen detection tests and also PCR tests. But for the atypical organisms like chlamydia and Legionella, we don't have many tests in Sri Lanka at the moment. Legionella also will grow on our culture media, but we have to use selective media for that. And the Legionella urinary antigen test we can use to detect in the urine, detect the organism in the urine. But only problem is MRI has the facility, but the reagents are not always available. Because of that, we may not be able to do it all the time. Therefore, and PCR also has a place in Legionella pneumonia. If there is a epidemiological or if there is a risk factor for Legionella pneumonia, it's available in the private sector, but not in the government sector at the moment. But since Niranjan asked about this rapid molecular tests, which are available in the country now, actually the BioFire, we have 2 machines in the government sector now, one in the cancer hospital where I work, and also in the teaching hospital Batikalo. But it's available in the private sector even before that. So there we use, it's a syndromic, it's a very rapid PCR test, fully automated. And the thing is, only problem is the cost. The cost per test is around, in the private sector, it's around 100,000 rupees. But in the government sector, without the other cost, so they provide us the kit for per test. Their cost per test is around 50,000 without other human resources and other logistics are not there in the, no, I mean, they are there, but we receive per test cost is around 50,000 rupees. So there you have a syndromic diagnosis. 2 panels are there for respiratory diseases. they have a pneumonia panel and upper respiratory panel for the respiratory diseases, and also meningitis panel, gastro panel, and all these other panels are there. So in the upper respiratory panel, we have, because upper respiratory infections are mainly caused by viruses, so they have more viruses than about 4 or 5 bacteria. Like as far as I can remember, the bacteria are Bordetella and Mycoplasma. So all the other viruses are there. In the pneumonia panel, you have majority of organisms which can cause typical organisms, atypical organisms, viruses, and also, those are the things. And with the antibiotic resistant genes, that is very important. I don't say, I can't say it is useful in, very much useful in community-acquired pneumonia, but in hospital-acquired pneumonia, yes, identifying resistant genes, there we can, because the results, within 1 hour, you can get the results. The problem with community-acquired pneumonia is the quality of the specimen. So if you, more than half of the sputum cultures we get in our laboratory are not in good quality. So if it is a good quality specimen in, severe pneumonia, we can use this test, but otherwise it will be, if we use it for a low quality sputum sample, it will be a waste.
Yes, sir. Thank you all speakers for excellent presentations. My question is based on Sachini's talk. Sachini, we have around 5,000 deaths due to pneumonia annually. But still, pneumonia is not, as far as I know, a notifiable disease. We had discussions when Sujata was the president of the College of Microbiologists, whether we should have pneumonia as a notifiable disease. We see on our WhatsApp groups, we share X-ray, CT scans, para-influenza, probably community-acquired MRSA. But that's just a comment about that have pneumonia not being a notifiable disease. Sachini mentioned about steroids, the steroids in severe community-acquired bacterial pneumonia. The panel's thoughts on this, what is the role, and who would you define as a severe community-acquired bacterial pneumonia? Who would get steroids? These are not patients who are hemodynamic compromised on vasopressors. And what regime should we practice? And how would you approach these patients with severe community-acquired bacterial pneumonia and the role of steroids?
Would Sachini answer that? Yes.
It's in the 80s guideline, they clearly define the criteria to define a severe pneumonia. So any patient who fit those criteria should be given steroids. So I think the choice and dose, that part is the vague bit. So so if the patient is in septic shock, we usually give the dose recommended for septic shock. For others, I didn't really come across a dose, so I don't know if anyone else has any recommendation, but I would usually give the same dose.
At NHSL, Dr. Dilshan and our internist Afla knows that when we see referral in patients with severe community-acquired bacterial pneumonia, if influenza has been excluded, not COVID, of course, we give DEXA things. We practice hydrocortisone 200 IV infusion 24 hours for 4 to 5 days, or 56 hourly. These are not patients who are hemodynamically compromised, who are on vasopressors, where steroids may have a vasodilator augmenting effect. But these are purely for and a step down with oral steroids, where we go on to treatment of prednisone 30 milligrams for about 14 days, right? There is evidence that this has 28-day mortality reduction, right? My view is that we, as a specialty, along with the intensivists, along with the microbiologists, should give a clear directive on the role of steroids in severe bacterial pneumonia. So then only these things will become practice changing and become meaningful and will have good patient outcomes. So I think that we should look at this, and anybody in the panel, whether would like to comment on this.
Now, like Sir said, in fact, use of steroid in severe community-acquired pneumonia, it has been a debate for some time, but after 2022-23 trial and the publication, use of hydrocortisone on those patients, clear mortality benefit, and in some studies it showed up to
20 to 30% mortality reduction in those patients over 28 days. So the question here is how efficiently, how confidently we are diagnosing these patients as severe community-acquired pneumonia. That is number one. Because now we all know that the ATS guidelines have clearly given the criteria. However, the use of those criteria also depends on the way you record those events. As an example, somebody who is coming with severe respiratory distress who need ventilation may be having some other comorbidity, and which is with pneumonia, and in those patients recognizing as severe pneumonia and starting steroids can be sometimes challenging. So defining severe pneumonia is very important. That's the paramount. Number one. Number two, after that, how confidently we are excluding the viral pneumonia. So we all know that is another challenge, because most of the time we have not taken a proper history, and we must never forget that basic thing, and the history and the examination to find out this patient had a viral pneumonia picture. And we see quite a lot of patients even after intubating and ventilating, when we do the biofire and viral studies, when we do, they have a high titer of influenza, and patient has been treated for community-acquired pneumonia for over 5 to 6 days, even sometime 1 week. So in that context, in our limited resource setting, why I say limited resource setting, because our patients are not screened at the outset for viral infection. So in that context, I think as a blanket, cover with IV steroids or steroids for severe community-acquired pneumonia is challenging. I think it is a decision. That's why I think, like Amtazar said, we have to have a consensus with the intensivist and the microbiologist at which point we are going to start steroid. Because of those two challenges, I think we should not be promoting at once the use of IV hydrocortisone.
I think the basic thing, I think you highlighted two very important things. And according to Sachin's lecture and the consensus, influenza, you had to avoid steroids, and that is one of the major cause of viral infection causing a secondary bacterial infection. So we have to be careful about it. And the second thing is the physiological deterioration or the decompensation should be explained by the pneumonia itself rather than a coexisting comorbidity. Then I think we can justify it. I think Dilshan is here. I'm really happy that you're here, Dilshan. Any comments from you? So steroid has come up very recently, in 2024, for community-acquired pneumonia, ARDS, and it was there as a septic shock. But the dose that we're using, 56 hourly of 200, even in septic shock, that we give for vasopressor spare to lower the vasopressor requirements, that's not shown to increase the the hospital-acquired or ICU-acquired infection rates. So the dose that you use may be beneficial in a severe form of disease that you're treating as a high mortality, may overweight the benefits by the side effects of the steroids, because we are not using very high dose of steroids. So that we have to consider when challenging cases. But the problem comes with the influenza, I guess, because you give steroids in the active influenza phase might cause problems, or so that we may have to address when you are using steroid. But anyway, if a patient comes to ICU, they come into the category of severe pneumonia. Or if you require mechanical ventilation, they come into the category of severe pneumonia. So the problem comes in the hospital ward setup, whether you use steroids and how do you exclude influenza. The other question I want to ask regarding the biofire. Now it's only used in few centers. I don't know, costly, but I feel the amount of antibiotics that we use will be more costly than not treating the actual disease.
So probably it might be useful, but in our setting, that again, we might have consensus on what patients we're going to use it, rather than blindly using for everyone in the, not community, but even in the hospital setting, on what patient that we use. So if we can use it effectively, that may have a good, outcome for the patient as well as for the economy of the country, because, we see even a community-acquired pneumonia has been treated with fourth generation cephalosporins. So that's one thing. Other thing I just want to ask, it said the patients who are coming with community-acquired pneumonia who had a recent hospital stay or hospitalization. If you were to cover MRSA in either vancomycin or linezolid, which one would you prefer? Whether it's a linezolid or vancomycin?
Yes, I think that was a question actually I wanted to ask. And before answering that, Dr. Malmalia, I think I wanted to raise that question, important question of community-acquired MRSA. Because even though we think that it is uncommon, it is sometimes common, and the delay in diagnosis can significantly have consequences to the patients. So, Aflav, we know that we don't usually do the swabs and other things. In a patient who has no history of recent hospital admission and no previous MRSA swabs, but some people come as MRSA pneumonia in a retrospective way when we diagnose. Very quickly, any particular clinical feature or features or radiological features that might push you to think the possibility of MRSA?
So, very difficult question to answer pinpoint like that, because it's not that easy, especially in the clinical setup, to differentiate. Now, we must understand community-acquired staph pneumonia is not uncommon. And also, we need to understand in the background of previous viral infection, chances are quite high to develop staph pneumonia on those patients. So, again, your history is very important, whether for you to suspect. So, basically, what we need to know is we have to have that clinical suspicion before we decide on anything else. So, Sachin clearly said at which point we should suspect. But for the question to answer to the Niranjan's question is, now, if you have any clinical suspicion of your previous viral infection or ongoing viral infection, and those infiltrates are rapidly progressing, and we know sometimes this staph pneumonia changes can happen over hours. So when you think that there is the X-ray changes or the infiltrates are happening over hours, obviously we should expect clinical deterioration also with that. So in that context, I think it's a strong suggestion to say that it is MRSA or pneumonia is going on. In that context, starting antibiotics, we will be going to the next question. What Dilshan mentioned is to start immediately on that. So in addition to that, we need to understand if we have any clinical suspicion, especially in the context of severe pneumonia who is requiring some respiratory support or in the form of ventilation, I think we should not hesitate to start on it.
Can I?
Three options. According to the scientific basis, I think if you can, because we have lack of time, clindamycin, vancomycin, linezolid. Out of the three, if a patient who has not been recently admitted to a hospital, what would be the best antibiotic that you would advocate to start in a normal medical ward setup, and why?
For community-acquired pneumonia, if the patient is in sepsis, always you have to give a bactericidal antibiotic. So, linezolid and clindamycin are not bactericidal. So, I always prefer vancomycin if patient is in sepsis. But vancomycin concentration in the tissue is not very good. But on the other hand, linezolid tissue penetration is very good. And there is an oral preparation available when you want to step down. So, but even in other countries, combination of two anti-staphylococcal agents are recommended, especially in staphylococcal septicemia and pneumonia, because of the virulence. So initially you can combine both. And then when the patient is settled, you can step down to oral linezolid. Then, we can, in a patient is in sepsis, we can use both. But we have to give vancomycin because it's a bactericidal drug.
But in case PVL producing organisms in stuff, I think vancomycin can be little challenging.
Yeah, it is. But still, it is the recommendation in most of the guidelines.
If I make a comment, severe community-acquired MRSA has been a challenge, and I have personal experience about that. Dilshan knows, and BioFire has been a game changer in that. In which within a few days we were able to identify MRSA, and my subsequent reading on this showed that there is a Sri Lankan strain where previal production is there. Identified Rajaratnam University 2015. Severe community-acquired MRSA. These people have been traveled to the US and other countries, and in this country, they have identified the Sri Lankan strain of community-acquired MRSA. 60% produces PVL, severe pneumonia, and I found that ferritin is a useful marker. We see ferritin, early rise in ferritin, but we should not see in bacterial pneumonias, other pneumonias. We'll see in cytokine storms, but much later, day 5, day 7, like we saw in COVID. So in our setup, ferritin is a useful marker. And as Safla said, the protein synthesis and producing this PVL toxin, only clindamycin and linezolid will inhibit protein synthesis. And as you correctly mentioned, vancomycin has issues because we have to do trough levels, and giving a vancomycin from peripheral lines is very difficult. And we don't put early lines or lines. We don't do arterial lines. We give to peripheral line. Heavy antibiotic loads to these peripheral cannulas. So it can be a problem. So with regard to protein synthesis, I would agree with you that we would go with a bactericidal drug like vancomycin and linezolid, because linezolid oral absorption is good. We don't have to give IV. So oral absorption is very good and lung penetration is good. So I think to answer that question, vancomycin, linezolid would be a combination I would go. But clindamycin has a protein synthesis effect, but 50% are MRSA are resistant to clindamycin. Teicoplanin again, loading. Yeah. So teicoplanin has been our go-to antibiotic. Now MRSA antibiotic, but it takes time. You have to give loading doses. Tissue penetration is low. It doesn't have any effect on the protein synthesis. So I think oral linezolid, and if you are thinking community-acquired MRSA, oral linezolid, vancomycin should be the go-to combination.
Right.
Sorry, can I just add one thing? So most of these guidelines are Western guidelines, and these patients, particular nursing homes or whoever comes in regularly to hospital, are regularly screened with nasal swabs to see if they are MRSA carriers. So we work in a setting where we don't have that information. So maybe it's time that we start these basic things because at least to identify those who need a step cover early. Because they give us risk factors. Yes.
Right. There's some data on it because high Cipro use in Colombo, 13% are MRSA carriers.
Yes.
We have high use of ciprofloxacin. I think some agree. There is some data on that. 13% are MRSA carriers. So as you rightly said, when these people come to hospital, maybe we should train them.
Right. Okay. And in the interest of time, I think it's a very important discussion, and I think most of the very important things that we had to highlight, especially in the local setting, was highlighted. So I would love to get Dr. Saman Kapilavansha's input on, especially I know that you were in a center where you were able to function as a plural lead in United Kingdom, and then same time you have done tremendous work in the peripheries, including Badulla, Ratnapura, and various areas in the country. So regarding pleural infections, one important thing, as Chandana highlighted, is that sometimes differentiating tuberculosis and empyema, differentiating them. So first clinical scenario, when you have a lymphocytic effusion, but the ADA is not what we say highly likely. We'll say the cutoff is 40, but it's about 35, 36. What would be the clinical approach that you would suggest the clinicians to undertake?
Thank you, Niranjan. So it's always when you manage patients' effusion with pleural infection, always you need to go through the history. History is the must.
see whether this is a chronic infection with all these constitutional symptoms and everything. So, and depending on the pH, so we can think that whether this is a pleural infection, as he mentioned, everything according to the PTS guidelines. But differentiating pleural effusion, whether this is empyema due to bacterial infection or TB, again we need to see whether the full report where the neutrophil is predominant in bacterial infection and lymphocytic predominance in TB patients. But we can't, he correctly mentioned that we can't exactly rely on ADA, because ADA can be high in bacterial infection as well. So we need to think about, see whether the patient is having associated symptoms. Like, for example, X-ray might show some upper lobe involvement, and MAN2 test may be positive. So we need to consider the overall picture of the patient rather than we just go through the investigation of the pleural fluid.
In this patient, we'll say the patient is having predominant lymphocytic pleural effusion with an ADA is in the margin. Would you advise to go with a medical thoracoscopy, or how would you proceed?
Yeah, medical thoracoscopy. I prefer to do medical thoracoscopy. I was thoracoscopy man. So yeah, even though it's not in the guideline BTS, because BTS guideline is not recommended because it's not available freely in the UK. So in our centers, we have, I think it's freely available. So for all the effusion patient, I prefer to go for thoracoscopy and take biopsies. But that is histology will show us the diagnosis. Yes. Because otherwise, we in UK also what we do is we have pleural clinics, so we aspirate patients, send for investigation, wait for investigation. But medical thoracoscopy is straightforward. We can see the lesions, we can take biopsies. The diagnosis is very rapid. I prefer that.
Yeah, especially in these marginal cases, sometimes there might be underlying malignancy with malignant deposits, and medical thoracoscopy, as you said, it is almost widely available. All of the consultants, the pulmonologists will be able to perform, and it will give us a very, very early diagnosis, and it will prevent unnecessary delays in starting treatment for malignancy as well as tuberculosis. And thank you very much. So we have an eminent thoracic surgeon here now. Russ, now, according to Chandana and the BTS management, isn't it, Chandana? We want to get the surgeon's input at the end when we can't do anything else for the patient. So would you agree, Russ, or would you like us to send these patients a little bit early? And if you are sending, what would you like us to do, that the physicians and the respiratory physicians?
It's a very important question, Niranjan. Actually, that you all know that that empyema is divided into three phases: exudative and fibropurulent, as well as then organizing. A treatment also different in various stages. And the reason is, as you know, that in exudative phases, it is just fluid, that you don't need to do any treatment. But that fibropurulent and exudative phases, that overlapping. And in fibropurulent phase, what happens is that fibroblast forms and that loculation. And there, that what we have to do is we have to just evacuate all the pus and fibrinolytics. But in the organizing phase, what will happen is all the fibroblasts may thicken the visceral and parietal flora. The main important thing is we have to take out all the content, as well as we have to completely remove the pleural peel, which is over the lung, to re-expand the lung. Otherwise, lung will collapse, persistently collapse, as well as fibrosis within the behind the pleural peel. So you have to completely peel it out. Then that air leaks and everything, all the complication happens, because particularly when there's inflammation going. Not only that, even if you remove the pleural peel and re-expand the lung, it won't pleurize completely, because we have to remove the inner lining of the chest wall, which is parietal pleura, because otherwise chest wall will not expand fully to re-expand the lung and that normal respiratory function, and patient will feel some chest tighter. So, and my colleague is here, that Handagal, that we all do these surgeries at thoracoscopy. Generally, if you do surgery at the fibropurulent phase, it is just 30 minutes operation. But if it happened to go through the surgery in organizing phase, it takes hours. Even still, you may not be able to completely rescue the lung and the patient's respiratory mechanics. So the best thing is early referral. But there is another problem. We all know this is a disease progress, and timing is depending on the patient presentation and pre-hospital antibiotics and the level of the disease when they admitted. Currently, we all know that some kind of irrational or that self-antibiotic usage like things cause that even on admission, patients are in fibropurulent phase or even organizing. So the best thing is we have to mainly depend on the clinical scenario. So my advice is if the patient has rising fever, sepsis, irrespective of antibiotics, and rising inflammatory markers, and if you have placed a tube, there is a thick pus and not respond to the chest drain, as well as if the patient imaging shows localized collection or trap lung or large collection, I think that is the time you have to send for thoracic surgery, because at that time, if you refer, we can do a quick surgery and they will have very quick recovery and complete recovery without having any complications and very minimum complications, and we can reestablish lung and chest function quickly. So that best thing is, if there is doubt, better to send these images to us through WhatsApp or any other communication modality you can use, and then we will advise. And it's like a small MDT we all used to discuss over the phone.
I do it all the time, and all of you, all 5 of you, the thoracic surgeons are very so brilliant. And whenever we have a issue, ask, just send, and you will do the needful. I'm really thankful, and we are really appreciative about your services. One thing, Russ, as I said, sometimes medicine is rather complicated, isn't it? Sometimes we have apparent empyema, pus coming out, and sometimes the neutrophils are also high, but sometimes it can be TB as well. Right. The first question is to Dr. Saman Kapilavansha. In that aspect, sometimes TB empyema is very difficult to differentiate from bacterial empyema. Sometimes the infections coexist with each other. Do we have a strategy, or would you suggest a strategy to differentiate both, or how would you proceed with that in that type of patient?
Yeah, differentiating it is a bit, as you said, it's difficult. But if you can do thoracoscopy, then we can see the seedings everywhere. So it's nice. Then you can take biopsies. So that's I think the important thing to differentiate this. And because when you see thoracoscopy, when you do the thoracoscopy, you can see nice. It's not nice, but it's for us it's nice. But you can see the seedings. So then. So other thing is especially the TB. So there may be lots of fibrosis and the septal formation, and it's so complicated. The effusion will occur in TB patients, especially. So when you look at those patients, so the management point of view, I think thoracoscopy and then the other thing, the surgery is the most important part.
Especially in this context, I think. Now, earlier, I know that all the recommendations were against doing gene expert in pleural fluid. But in this instance, I think specifically because now the gene expert ultra is here, where the sensitivity has gone out, I think it is a very useful tool, especially in loculated effusions where you can't do thoracoscopes. Maybe an aspiration, if we are having clinical suspicion, maybe a gene expert would be the best choice of forwards. Thank you very much. Do you want us to exclude tuberculosis before you send the patient?
Basically, that it is sometimes impossible, because you may have the sputum negative tuberculosis, because it is kind of extrapulmonary tuberculosis. But that if you see the images, the disease behavior is a little bit different, because that you may have very thickened visceral pleura with rolled out edges, and those things are classic in tuberculosis empyema. And for us, that TB empyema treatment is a little bit different because that we may need to do remove the peel carefully because that underlying lung is not very healthy, and there are high chance to have bronchopleural fistula following surgery and persistent collapsed lung. And at that time, we may have to keep the thoracostomy even for a while until we treat the patient. But I think the best suggestion is please do not insert chest drain. If you suggest TB effusion, because you may convert into empyema. Otherwise, most of the TB effusions spontaneously settles when you give treatment.
Unlike empyema, it resolves to a certain extent. Sometimes they might have a residual pleural thickening, but isn't it there? Yeah.
But again, it's depend on the size of the pleural effusion.
Definitely, yeah. If it is large and if it starts in compromise, and we might have to. Okay, so we will switch gears now. So we have an eminent rheumatologist, Tanushka here, and he's very interested about CTD-ILD. And now, Tanushka, now we are basically, what are the lapses, now RTI exclusively, beautifully put on the guidelines for a patient who is already diagnosed of CTD-ILD. Now, you are following up patients with rheumatological conditions, and sometimes the patients who are having lung diseases will come to the physician first or sometimes to us as well. So in your experience, what are the lapses or what are the areas that we should improve in improving these patients' outcomes in the Sri Lankan context with CTD-ILD patients?
One of the common scenario we encounter both as pulmonologists and rheumatologists is when you encounter a patient with interstitial lung disease, you tend to do, since one of the main treatable condition out of the CTD-ILD cohort is the CTD-ILD, out of the ILD. So you tend to do autoimmune screening. In autoimmune screening, for instance, antinuclear antibody or rheumatoid arthritis, when you see a positivity, the dilemma comes whether there is if there's already established diagnosis, or if it's easy to establish a diagnosis of a CTD, it won't be a problem. But if it's only the lung involvement is there, which is beautifully termed as the interstitial pneumonia with autoimmune features, is the bit of a diagnostic dilemma, whether to go ahead with immunosuppressive therapy or what to do. In Sri Lankan context, what we see is we see a ILD patient. This could be UIP pattern or an inflammatory pattern like an SIP or icing. And you do antinuclear antibody, ANA become positive. 1 in 80 ANA positivity is universally seen. A very quite common scenario which we encounter. But mind you that positive antinuclear antibody in low titers, for instance, in 1 in 80, 20% of the normal population can be ANA positive. So it doesn't, synonymous with the IPAF that we need to keep in our mind. It is not ANA positivity with ILD is not synonymous with IPAF, interstitial pneumonia with autoimmune feature. It per se is not an autoimmune feature. So how to tackle this is a problem. I think part is yours, part is ours. You definitely need a multidisciplinary approach from a rheumatologist to see whether this. So in this scenario, this could be IPAF. If it is IPAF, this could be the initial stage of an evolving CTD. We are seeing an CTD with lung involvement and other extrapulmonary features are yet to come. Or this could be the lung dominant autoimmune, where the lung dominance. Or this could be an incidental finding where you have interstitial lung disease, and incidentally, you have the positive immune screening. So these are the three we need to understand and to work on. So my understanding is doing an immune screening, antinuclear antibody itself, the autoimmune screening itself gives you a lot of clues if you do it properly. Now, for instance, if you take a look at anti-nuclear antibody, the method you use, the immunofluorescence is the standard and recommended by both ACR and EUL. The ELISA can mislead. And the immune pattern, the staining pattern, since it's an immunofluorescence study, if you follow the IFM immunofluorescent assays, the immune staining will give you a lot of hint whether this is a false positive or whether this is a autoimmune things. Like, for instance, core speckle patterns, centromere patterns are more specific rather than homogeneous or fine speckle patterns. And the endpoint theta, so more the theta. So what we see is most of the times instances in your day-to-day clinical practice is a 1 in 80 positivity. So if you ask for a request for an endpoint theta, you see really diluting it and see the higher theta gives you higher specificity and sensitivity, higher specificity actually. Plus, and then from your point of view, the HRCT would tell you if this is a predominant inflammatory features, which is not my, it's not my specialty, but HRCT will give you whether this is inflammatory or fibrotic. If it is inflammatory, some HRCT features, as far as I know, are peculiar to certain autoimmune conditions like scleroderma. RA has some hints in your HRCT that again tells you, plus the clinical features. So that is something which I wanted to highlight there.
Exactly, that actually, we wanted to know as well, because, sometimes, especially when the patient comes with ILD, it's our duty to, arrange this particular investigations and then send it to you so that you will be able to look at the patient as a whole and then you can make a decision about it. Dr. Atihai, now, HRCTs, when we ask for a date, the date comes in about 3 months, 6 months. So sometimes it's very difficult, but, if we discuss with the radiologists, we might be able to get it done. But they are under tremendous pressure as well because they are doing the CTs on a regular basis. Anyway, out of this, when we suspect, for example, the rheumatologist suspects ILD, sends to us, the X-ray is there. Other than HRCT, are there any novel developments that we can use to identify early interstitial lung disease? Quickly.
Even though they have not recommended ultrasound scan, we can do it and see the B lines. But if it's more than 20, it's suggestive. But the guideline didn't recommending the ultrasound scan, but it can coexist with other diseases. So they only recommend HRCT check. And I just want to add for the autoimmune panel. So it will give more with if it when we are doing the ANA with a pattern, if it's a cytoplasmic dense, and if a patient having even though it's a cytoplasmic dense pattern, then with a fine coarse dense, then we can suspect myositis on this patient. If the clinical features are suggestive, then we can ask for the myositis panel. Even with a nuclear pattern also, nuclear coarse pattern, and we can suspect MCCD, mixed connective tissue disorder on this patient, and we can ask for the ENA panels. So we can guide with the ANA, and at the same time, the HRCT also have some more patterns like straight line patterns, which is more on the connective tissue disorders, and the anterior honeycombings, which is in the most in the systemic sclerosis. So this will also guide with what sort of connective tissue disorder we have in dealing with. And the myositis mostly come with organizing pneumonia with NSIP. So this also guides us what is the underlying connective tissue disorders in this patient.
Certainly. Thank you very much. And thank you, Darishka, for that input as well. So I think Dr. Manmadan presented a beautifully, that is the most controversial topic, right? Because there is no exact guidelines for us to follow up in copulmonale. There are still people who advise sildenafil, against sildenafil, for the bosentan, for diuretics, against diuretics, but probably it will depend on the patient. But anyway, Dr. Sampath Visanavasan is doing a huge amount of work on pulmonary hypertension in Sri Lanka. And Sampath, now, especially when as physicians or respiratory physicians, when we suspect pulmonary hypertension in a patient, in the Sri Lankan context, what is the best way forward that we should go in diagnosing or confirming pulmonary hypertension in this particular patient?
Right. First of all, thank you very much, Niranjan, as well as Ceylon College of Physicians and College of Pulmonologists to for inviting me. Yeah, taking this controversial issue also. Now, this is actually a real problem for us because from your side or my side, it's extremely difficult to say one has pulmonary hypertension by clinical features or by examining alone. We need supportive investigations. We have definitive guidelines. What it says, what we need is to measure the pulmonary artery pressure in a cath lab, which should be more than 20. So that's definite black and white. But the problem is whether and how we can get into this. Now, in Sri Lankan setup, as you aware, that the catheterization laboratory services are very poor, even for emergencies. Sometimes the queues are more than 1 year, so extremely difficult and difficult investigation. It's extremely difficult for us to find time in a cath lab. So then indefinitely, the current practice, even though it's inappropriate or probably not the guidelines, according to the guidelines, we had to stick to the some echo features. So what we really need to understand, because now as a cardiologist, we have some idea about the echoes, but you have some idea about the echoes, but it's extremely likely that you are misleading more than us when you are making the diagnosis. On echo, someone else has done. It's not, you are not doing echo. So basically, our practice, actually, what I am saying, most of you are making the diagnosis of pulmonary hypertension only on TR gradient. And the TR gradient also, if you are seeing clearly, even within different cardiologists, sometimes will define it mild to moderate and severe on different criteria. So you may be puzzled what to believe and what not to believe and how to tackle these problems. Now, there are lots of pitfalls in echo diagnosis of pulmonary hypertension. That is why until up to this point, it even hasn't come to guideline levels. You can't have a good correlation. You can have some correlation, I'm not saying not, but you can't have a correlation up to the level of firm diagnosis by echo alone. So that's the problem. But if you're now, say, we suspect pulmonary hypertension if the tricuspid gradient is, I would say, more than 35 or so. And we usually tend to have idea if it is 35 to 50, it's mild, 50 to 70, moderate, more than 70, severe. So that's the TR gradient, the assessment roughly to say mild to moderate or severe. Having said that, this TR gradient is changing even in the same patient at a different point because of different other issues. Because one common thing is fluid status of the patient, right? So the TR gradient can be changed. And then again, whether your tricuspid valve competency, if you have a good competent tricuspid valve, even with a significant level of pulmonary hypertension, you may not have a TR significant. If you don't have a TR, there is no way of measuring it. And if your patient has right ventricular failure, you can imagine the TR check would be much lesser than otherwise, where the right ventricular function is good. And then again, you are underestimating a severe pulmonary hypertension with mild to moderate or something like that. Or otherwise, it invariably depend on how and who measures it. Because you have to, if you are measuring the TR gradient, it has to be Doppler waves should be parallel with the jet. And sometimes it's extremely difficult for you to get, especially in obese patient and so on. and especially in the peripherally, the echo machines that we have. We know that our cardiologists, how practice they in the peripheral center. So all those things matters with the TR variant. What I wanted to actually give a message now, if it is not a decision making place, probably echo is a good tool to get some idea in our setup, even though it's not the best. But when you have or when you want to take a decision making or a point that where you need to change your medicine or you want to do something which is very much crucial for the patient, at least probably you should ask echo by a consultant level whether this is um, I'm going to do this, whether it's appropriate or not, or if the facilities are available, ideally for RHCC. And this especially comes into the primary pulmonary hypertension because you all are aware vasoreactivity is very much important to guide the treatment, which is we were just talking, we are not doing that. So I think now that we are thinking about heart transplant, heart and lung transplant, everything. So these things has to some more other way come to the picture. We have to get this into our practice some more other way. And collectively, my feeling is we should do that. And we have to find as cardiologists some time allocated for right heart catheterization nowadays. Hopefully, I think we should be able to do. At the moment, message is TR variant is sometimes misleading, but for the common practice that you can use it. But if you want to change your very crucial, don't take any crucial medicine, but the crucial decisions only on TR variant, especially if you have only one echo, ask for expert opinion.
Another a difficult question. So, patient with COPD, same clinical features. One has pulmonary hypertension diagnosed by echo. The other says no pulmonary hypertension. Is the treatment approach, because we really don't have any evidence to add anything for a patient with diagnosed pulmonary hypertension. Would your management differ, or would you like to think otherwise?
Yes, sir. So regarding this kind of situations, anyway, so I will definitely go back to the basic. So I will start with a very detailed history about that, how is the symptoms, like especially the cough or progressive breathlessness or any evidence of syncopal attack and kind of this. So in addition to that, we can, even though we can't do a right cardiac catheterization, we can do some functional assessment like spirometry and bronchodilator reversibility test, and also we can do some DLCO kind of thing. So, and we can like come to a conclusions like how is the like severity of the COPD or airway disease, and then we can like treat according to the like COPD category with like bronchodilators and steroids, and we can wait and watch how the patient is improving. Even if it is a patient is not improving with like adequate steroid adequate inhalers, actually not a steroid, it's a triple therapy inhalers and the oral steroid. And if the patient is again symptomatic, and we can repeat the 2D echo as said, like suggested with the cardiologist echo, and to assess the pulmonary hypertension level or like pulmonary hypertension severity. And if the pulmonary hypertension severity is disproportionately high compared to the underlying lung diseases, then I would try for that anti-pulmonary hypertensive medications.
Yeah, I think that is the important point that we have to raise, isn't it? So sometimes a mild COPD might have a moderate to severe pulmonary hypertension, which will not be explained by COPD itself. And if we deprive these patients of at least the available anti-pulmonary hypertension treatment, I think that will do harm than benefit, and especially in a patient who is having CTD-ILD, who might be prone to have more coexisting pulmonary hypertension because of the CTD rather than the lung disease itself. So these type of patients, we have to probably think about starting treatment. And as you correctly said, long-term oxygen therapy is one thing that might change the outcome of these patients as well. So Niranjan, one important question in this bronchiectatic patients. I think we think that most of these patients are post-infections and post-tuberculosis in the Sri Lankan context. Maybe we are missing a lot of PCDs, primary ciliary dyskinesias, because we really don't have the facility to identify any clinical. You alluded to certain clinical features like the sinusitis coexist with bronchiectasis. Are there any, for the audience and the physicians, are there any specific clinical features that we should look for to help us probably think about PCD in a bronchiectatic patient?
The main thing is about if you're finding a young bronchiectasis, especially the bronchiectasis less than 50 years, and when they have some kind of like early onset disease. So most of these patients sometimes present like around in their 20s, right? And but when you are going through the history and examination is very important, and then you can find out these patients having some chronic rhinosinusitis, like that case I discussed. And sometimes there is other kind of features as well, some kind of like a recurrent infection since childhood, and there may be history of infertility. And other things regarding a CF, sometimes they comes with some kind of like a GI symptoms and some features of pancreatitis, some early onset diabetes as well. So then you have to think of that we are dealing with something problem with the dysfunction of their host defense. And the other things about sometimes most of these coming with some autosomal recessive conditions. So then it is very important to know about the consanguinity and things as well. And sometimes there are patients present with some incidental features like a dextrocardia or some like situs inversus. So in that kind of patients, it is very important to know to assess them for the bronchiectasis as well, because we know there are some conditions like Cartagena syndrome. There are some clinical trials. You have no need to do the specific investigations like FEED or any other things. So you can diagnose them with the clinical trial with the dextrocardia, bronchiectasis, and the rhinosinusitis. So then you can start the treatment. And the most important thing I want to highlight is if you are, because we are more prevalent with the PCDs, but the thing is we don't have the diagnosis as you mentioned. But the thing is you should go with the shared care because we have very good expert ENT team. So you have to manage the bronchiectasis, and you have to give the other parts from the ENT surgeons and the ENT team as well to manage the rhinosinusitis, because otherwise, if you're not control the sinusitis, it will progress the bronchiectasis and it will make you more problem and more.
Yes, I think in Sri Lankan countries, we have a huge amount of undiagnosed rhinosinusitis, which is there might be, causing the disease or might be a clinical symptom that might point to PCD, isn't it? Now, recently, my experience, I did a certain lecture, presentation on bronchiectasis, not in Sri Lanka, somewhere else. And at the end of the lecture, Rasnanka and Dr. Handagala, a thoracic surgeon confronted me and said, "You didn't tell anything about the surgical interventions for bronchiectasis." Right. So, Russ, I think this is the stage. What are the surgical interventions that you can have for bronchiectasis, and when we should refer to these patients to you as for these surgical interventions? Yes.
Basically, number one is if it is isolated to the segment or lobe, even sometimes single lung, we can do resection. It is to relieve the symptoms as well as it prevent the progression, because that progression is mainly spillage of contaminant to the other's normal lung will cause a progression. So we can stop. Furthermore, other main indication is hemoptysis. If there's hemoptysis, currently we can easily manage with single lumen ventilation and thoracoscopically, we can just resect it. The other important thing I have to highlight, sometimes isolated bronchiectasis is mainly due to endobronchial obstruction we usually missing. We may need to resect that obstruction and even sometimes save some part of the segments while resecting mainly affected lung. So, such as sometimes in bronchiectasis, even though it may be either both sides, few segments, sometimes we have resected several segments without any compromising lung reserve. Only thing is, if your patient has good lung reserve, you can take out some few isolated segment if it is not generalized bronchiectasis.
change the lives of the patient.
Yes.
And especially in young people,
Yes, it will improve their quality of life significantly.
recurrent exasperations are improved. And sometimes, we have young patients whom I think all of you have helped us to manage. And now one of them is actually thinking about getting pregnant and going because lung functions are now completely impaired. So changing of life. So I think that is one part that probably it's neglected because some of the guidelines doesn't actually look at the surgical aspects, isn't it, Narjan? Most of these guidelines, maybe because it's made by clinicians. So because we are fortunate because we have the thoracic surgeons in our fold, and so hopefully we might be able to think about developing our own guidelines for bronchiectasis in Sri Lanka and change certain things. So that is one important reason that we are having these discussions and MDTs. And as Amita sir always say, whatever we do, we have to have a follow-up plan. And I hope that sincerely we might be able to have a follow-up plan. Any comments?
Yeah, if I ask questions, you will be staying till morning, right? So, a brief thing on bronchiectasis. I know Niranjan did a gap analysis on bronchiectasis. We have collected data. We ourselves have evolved registries in bronchiectasis. The first encounter with Pseudomonas, our first isolated with Pseudomonas in a patient with bronchiectasis, what should be our approach? We see these recurrent episodes of Pseudomonas isolation. My personal belief is over the years with experience that we are not aggressive enough in treating the first isolate of Pseudomonas. So what should be our approach to this first encounter with Pseudomonas?
Yes, so in my overseas experience also, I think it should hit hard. That's what I explained in my lecture as well, because the Pseudomonas is a very nasty fellow and it will not clear from the lung and it will cause more problem and more recurrent exacerbations. So my feeling is, I think when you isolate it as the first Pseudomonas isolation, if the symptoms and the things are mild and its disease activity is mild, you can try with some like oral anti-Pseudomonas. So the only agent we have is the ciprofloxacin. So sometimes you can go like a 500 BD, or sometimes you have like a 750 BD, but you have to treat at least 2 weeks. But if the disease activity and disease severity is high, my feeling is you have to go for an anti-Pseudomonal IV antibiotic. So the patient should be admitted and go for 2 weeks, at least 2 weeks antibiotic, and followed that antibiotic. Ideally, you should start inhaled antibiotic at least for 3 months and then reassess the response. But if the patient's having a good response, then we have to decide whether we can stop the inhaled antibiotic or whether we can continue the inhaled antibiotics.
The doses of ceftazidime that we use, we generally tend to give 1 gram TDS. That I think we should go for higher doses.
Yes.
The recommendation is 3 gram TDS, but we at least go for 2 grams TDS. As you said, 14 days, and then we follow them up with gentamicin nebulization. We train them to nebulize gentamicin at home, 3 months of gentamicin nebulization, along with your other secretion clearance airway management techniques. I think one of the most important things is when you come into bronchiectasis, our first isolate of Pseudomonas, how aggressive we should be. So this is what which we prepare. I think so you will agree. This is clonal proliferation. Now, I think the same trend will go on evolving. No, I don't think there's reinfection with Pseudomonas. So I think we should be aggressive enough in eradicating Pseudomonas.
Yes, and especially in our part of the world, I think we are careful about Klebsiella as well. The recent studies by the Embark India has shown that especially Klebsiella has a very high mortality compared, when we think about compared to the other countries as well. So yeah, it is common actually. We have about 2 or 3 patients at the moment as well. So yes, unfortunately yes, and we have that situation in Sri Lanka as well. So any comments from the panelists and
from Niranjan? Yes, I have the word. I totally agree with what Damika said about the empyema as well as bronchiectasis. With regard to the two, for empyema, if you don't refer to us early, especially if it's the third stage, sometimes even if you do decortication, lung may not come up. So eventually the patient will end up in sort of a colostomy, like we call thoracostomy, open thoracostomy, which is a lifelong misery actually. So that is one thing. With regard to bronchiectasis surgery, compared to lung cancer surgery, we do prepare patients well. And we need to give good microbiological cover as well as the good chest physiotherapy, because we want to put the sputum amount. We put actually sputum charts. We want the sputum load to be low just before surgery.
So we admit the patient beforehand and give physiotherapy, and then only we do. Otherwise, our complication rates will be high, and even the patients can die. That much I wanted to add to them, because everything else I agree.
Yeah, thank you very much. I think it has been a big, the start was brilliant. The 5 speakers stick to time, and they delivered an excellent guideline-based management plan that will be useful for every levels of physicians as well as respiratory physicians. And then we were able to actually, within the limited time period, about 40 minutes, 45 minutes, even we have gone about 10 minutes, 15 minutes more. We would have loved to have a more chat. Maybe we might get together in a different circumstances in the evening over something, and then we can have a chat. But anyway, so I think we had a very productive session today, and I would like to, on a personal note, thank Dr. Handagala, our president, as well as the president of the CCP, Dr. Hiruni and Dr. Dinuka, together with their CDV teams who had done a brilliant job, and all the panelists today. Sampath, thank you very much. Afla, Dr. Saman Kapilavansha Ras, Dr. Saman Mali, and Danushka. And we will work together, and hopefully we will be able to improve the patient's outcome. That is the main importance of getting these connections together and working together as a team, so that our patients will benefit. And the brilliant speakers, you make us proud. Thank you very much.
Panelists, please remain on stage. I would now like to invite the president of the Sri Lanka College of Pulmonologists, Dr. Sumana Handagada, to present a token of appreciation to our resource persons. I invite Dr. Dhammika Rasnayaka to receive this token of appreciation. I invite Dr. Saman Kapilavansha to receive this token of appreciation. I invite Dr. Afla Sadiqeen to receive his token of appreciation. I invite Dr. Sampath Itanavasam to receive his token of appreciation. I invite Dr. Danushka Karunaratna to receive his token of appreciation. And I invite Dr. Samamini Gunasekara to receive his token of appreciation. I now invite Dr. Naranjan Disanayaka to receive his token of appreciation. Please come on stage for a photograph. Thank you everyone for that engaging discussion. As we come to the end of today's program, I now invite the Honorary Joint Secretary of the Ceylon College of Physicians, Dr. Dinuka Liyanagi, for the vote of thanks.
Good afternoon, everyone. Thank you very much for this excellent, fruitful session. Actually, this is the fourth time we have, in collaboration with the respective colleges, we arrange the fourth clinical updates. First and foremost, on behalf of Ceylon College of Physicians, I would like to thank Dr. Handagala, the President, Ceylon College of Pharmacologists, for arranging this excellent course. And obviously, my dear colleague, Dr. Ranjit Disanayaka, for this unwavering and dedicated lineup arranged to make this session fruitful. And all this expert panel and the audience, and stay tuned up with the CCP. So there will be much more coming in time to come. And obviously, I would like to thank our sponsors as well, the Loop team, and Mr. Sashi Bhushan and his team. Thank you very much. Have a lovely evening.